I didn't mean to throw you in.
Good.
No, yeah, no, I know, but.
You know how it goes.
The committee will come to order. We'll begin our hearing. Madam Secretary, I know how excited you are to be here today. Thank you for coming. I'll begin with some brief opening remarks, and I'll turn it over to Mr. Van Hollen, then we'll get started. First of all, I want to thank you, Madam Secretary, and our other panel of witnesses for coming to today's hearing on the future of Medicare. For years, politicians in both parties have not been honest with the American people about Medicare. The facts are clear. Healthcare costs are skyrocketing, growing at 8% a year. Medicare spending is on pace to double over the next decade, exhausting its remaining funds. 10,000 baby boomers are retiring every day as fewer workers are left paying into the program. Life expectancy was at 70 when Medicare was created. Today, it's 79. Nonpartisan experts, including the Congressional Budget Office and Medicare's own trustees, repeatedly warn of the looming insolvency of this critical program. These aren't Democratic facts, these aren't Republican facts, these are facts. Rather than advancing solutions to address these facts, too many politicians from both parties in the past in Washington have offered nothing but empty promises and false attacks. We deserve better. Our seniors deserve better. Due in large part of this committee's efforts, I believe that the debate is shifting to better reflect Medicare's inescapable math. President Obama was exactly right when he stated yesterday, quote, "If you look at the numbers, Medicare in particular will run out of money, and we will not be able to sustain that program no matter how much taxes go up. It is not an option for us to just sit by and do nothing," end quote. I couldn't have said it better myself. Senator Joe Lieberman, who has worked in a bipartisan manner to offer ideas of his own, put it well when he recently said, quote, "We can only save Medicare if we change it," end quote. The purpose of this hearing is to examine the changes to Medicare made by the President's health care law. Specifically, we wish to seek to better understand the Independent Payment Advisory Board's role in achieving the hundreds of billions of dollars of savings called for by the President. While I imagine we'll hear about the many different expansions of government buried in this 2,700-page law, today's hearing is simply focused on page 1,000, section 3,403. The Independent Payment Advisory Board, or IPAB as we call it, is a new executive branch agency created by the President's new health care law. The law empowers this board of 15 unelected officials with the authority to reduce Medicare spending. Unless overturned by a supermajority in Congress, the recommended cuts dictated by this board will become law. Bipartisan concerns have been raised with several aspects of this board. While the proponents claim that the beneficiaries will be held harmless by the board's decisions, how can IPAB impose sharp cuts to providers without an adverse impact on their patients? Given their unprecedented new power over Medicare, to whom are these 15 bureaucrats accountable? There are bipartisan concerns on this question. Democrats, including some members of this committee, have raised concerns with Congress turning its responsibilities over to this board. Seniors are also seeking clarity on the President's recent efforts to expand this board's power over Medicare. In an April speech, the President called for IPAB to enforce further restrictions in Medicare's growth rate, down to GDP plus 0.5%. The healthcare law is already driving Medicare's reimbursement rates well below the artificially low Medicaid rates. According to Medicare's chief actuary, Richard Foster, the healthcare law will pay doctors less than half of what their services cost at the end of the decade and down to 33% in decades ahead. Foster warns that these cuts are driving Medicare providers out of business and resulting in harsh disruptions to the quality and access for seniors. Yet the President's framework calls upon IPAB to slash reimbursement rates even further than this. It remains incumbent upon the administration to specify how this board will squeeze hundreds of billions of dollars of additional dollars from Medicare over the next decade, as the President has now proposed. I want to thank Secretary Sebelius, I seriously do, for testifying today, for coming here to address these concerns. There's no question that we have differences on how to address Medicare's unsustainable future. But I appreciate your commitment to clarifying this debate for policymakers and for the American people. I also want to thank our second panel of distinguished healthcare experts who will further discuss the merits of this approach. We look forward to testimony from former CBO Director Doug Holtz-Eakin, Grace Marie Turner of the Galen Institute, and Dr. Judith Fetter of the Urban Institute. Thank you all for our witnesses for the contributions to this debate, and I want to thank you all for joining in this conversation. With that, I'd like to yield to the ranking member, Mr. Van Hollen, for any opening remarks he may have.
Well, thank you, Mr. Chairman. I want to join Chairman Ryan in welcoming you, Madam Secretary, to the panel and to the other witnesses we're going to hear from later. And I want to commend you on two initiatives you've recently undertaken to help implement the Affordable Care Act. One are the rules, guidelines that you recently released to govern the exchanges, which will open the door to millions of more Americans being able to get affordable health care in the United States of America. The other that received less attention is your recently announced initiative to improve the coordination of care for individuals who are both on Medicaid and Medicare, called the dual eligibles. And as you have pointed out, using some of the innovative approaches in the Affordable Care Act, we can both improve the quality of care and save money through some of the changes you're proposing there. Those are important parts of the Affordable Care Act that, together with others, will strengthen health care protections for the American people, including provisions that have already taken into effect, including making sure that insurance companies can no longer discriminate against kids with asthma, diabetes, or other pre-existing conditions by denying them coverage, including making sure that young people up to the age of 26 can stay on their parents' health care plans, including providing tax credits to hundreds of thousands of small businesses who can now afford to provide coverage to their patients, and including beginning and ultimately closing the prescription drug donut hole in Medicare that many seniors find themselves trapped in. Those are some of the important improvements that have been made. So I believe that the fundamental question, the fundamental underlying question of today's hearing is, what is the best way to strengthen our health care system? And specifically, how do we keep the promise of Medicare and meet the challenges of Medicare, as the chairman has said? One way, one approach, is to build upon the very important reforms that were enacted in the Affordable Care Act. The Medicare trustees have found that those measures will indeed reduce the per capita costs for Medicare beneficiaries going forward, the increase in per capita costs, that it will help bend the curve, and that it will, in fact, extend the solvency of Medicare. We need to build upon those approaches. As we've heard in testimony before this committee from Dr. Rivlin and others, the Affordable Care Act opens all sorts of new avenues to try and modernize the structure of Medicare, which we need to do. We need to change the incentive structure so that it rewards the quality of care, the value of care over the volume of care and the quantity of care. And Mr. Chairman, we agree that significant changes need to be made to modernize the system in that way. The Independent Payment Advisory Board is simply one tool in the toolbox for getting it done. It creates a backstop or a fail-safe provision to ensure the continued solvency of Medicare if, and only if, the Congress chooses not to act, to take other measures to build upon the kind of changes we saw in the Affordable Care Act. And by the way, the IPAB is specifically prohibited by law from changing Medicare benefits. That prerogative is reserved to the Congress. Moreover, the latest CBO projections indicate that the rates of growth in spending per beneficiary are below the target rates of growth for fiscal years 2015-2021 set forth in the Affordable Care Act, and therefore CBO projects that under current law, the IPAB mechanism will not affect Medicare spending during the 2011 to 2021 period. So building on that approach is one way. What's the other approach? The other approach is a path set forward in the Republican budget plan, a plan that will end the Medicare guarantee and will force Medicare beneficiaries into the private insurance market. That plan is a double whammy a double whammy for Medicare beneficiaries for the following reasons. First, the Congressional Budget Office has determined that that plan will actually drive up overall health care costs. It changes the allocation, the burden, but it drives up overall health care costs. Why? Because providing that care in the private market is more expensive. And in fact, if you look at the history of per capita growth rates in the private market compared to per capita growth rates in Medicare, Medicare has actually outperformed the private market. And therefore, you're saying to those seniors, we're going to toss you into the private insurance market where you're going to face higher premiums and costs. Why is it a double whammy? Because as you do that, you dramatically reduce the support for Medicare beneficiaries from the federal government, dramatically. And as CBO has pointed out, by the year 2030, you essentially flip the burden from where it is today. Today, the Medicare beneficiary on average picks up about 30% of the costs, and the Medicare program picks up about 70%. By the year 2030, under the Republican plan, it's the reverse because of the rising costs of care and the diminishing support from Medicare. Double whammy. And I want to just really wrap up with this point because we've heard it said that what the Republican plan offers Medicare beneficiaries is really the same as what members of Congress get. The reason that is simply untrue is because members of Congress, by law, have a certain percentage of their health care premiums supported by the federal government, by the taxpayer. In fact, under what's called the fair share formula, that ranges from 72 to 75% on average, the share that's picked up by the federal government. Under the Republican plan, future of Medicare, we're going to be asking essentially Medicare beneficiaries to pick up themselves that cost, and the federal government will pick up only the remainder. So essentially, the flip of the deal that members of Congress give themselves. That's unfair. We have to make choices. We've said many times in this committee, to govern is to choose. We have lots of members on our side who are not wild about every aspect of IPAB, even in its backstop role. But I think we're united, and I believe ultimately the American people are united, that that is a better approach. We have to fix the kinks as we go along than the idea of ending the Medicare guarantee and throwing that decision not to experts who are confirmed by the United States Senate as a backstop, but the people on the front line will be the insurance industry. Under the Republican plan, it's the insurance industry that fixes the benefits, frankly, actually in consultation with what you guys say, federal bureaucrats, and they will set the premiums and they will choose, not the patients at the end of the day. So that is the choice. Mr. Chairman, thank you for holding this hearing, and I look forward to the testimony.
Thank you. Madam Secretary, the floor is yours.
Thank you, Mr. Chairman. I did. Chairman Ryan, Ranking Member Van Hollen, members of the committee, I appreciate you inviting me here today to discuss how the Affordable Care Act is strengthening Medicare for seniors today and tomorrow. My written testimony provides more detail, but I want to quickly highlight some of the steps we're taking as part of the health care law to fill the gaps in Medicare coverage, to improve care, and make the program more sustainable for the future, while preserving its guarantees for seniors and for people with disabilities. When Medicare became law in 1965, it served as a national promise that seniors wouldn't go broke because of a hospital bill. In 2006, the Medicare program added coverage for prescription drugs, which makes up a growing share of beneficiaries' health care costs. But we know that too many seniors still struggle to afford their medications, and that's why the Affordable Care Act provided relief to 4 million beneficiaries who fall year in and year out into the Medicare Part D donut hole, with in 2010, a one-time tax-free check for $250. And some of the beneficiaries who have written to me say they basically took that check and went right to the drugstore to help pay a part of their bill. And this year, because of the Affordable Care Act, those same beneficiaries are getting a 50% discount on covered name brand drugs. By 2020, that gap closes completely. We also know that many seniors were going without the preventive care that can help actually prevent illness before it occurs, lowering costs and saving lives. And in some cases, they were doing that because of expensive copays, and that doesn't make a lot of sense. So beginning this year, the law allows Medicare beneficiaries to receive recommended preventive services like screenings for colon or breast cancer, as well as an annual wellness visit without paying a copay or deductible. It's the right thing to do, and it's the smart thing to do, because it helps us catch small health problems before they turn into big ones. The law is also helping to improve the quality and safety of care for people with Medicare. Now, we know that there are model hospitals across the country that have adopted best practices to dramatically increase the quality of care. In fact, for every common medical error, we have examples of health systems that have significantly reduced or even eliminated them. And there's no reason why all Medicare beneficiaries shouldn't enjoy that same high quality of care wherever they receive it. And that's why the Affordable Care Act provides unprecedented support to help these best practices spread. In March, we launched the Partnership for Patients, an historic partnership with employers, unions, hospital leaders, physicians, nurses, pharmacists, and patients' advocates to reduce harm and error in our nation's hospitals. Last week, we were able to announce that more than 2,000 hospitals across the country have already signed up and are taking steps to improve care, aimed at two very important goals: reducing preventable readmissions and reducing hospital-acquired conditions. Under the law, we've also established the first-of-its-kind Medicare-Medicaid Coordination Office that Congressman Van Hollen referred to. The office is working with states to improve care for beneficiaries who were enrolled in both Medicare and Medicaid and often receive fragmented or duplicative care as a result. And through the new Medicare and Medicaid Innovation Center created by the law, we're testing a wide range of additional models for increasing the quality of care, from strategies for helping seniors manage their chronic conditions to new models in which hospitals and doctors who help keep their patients healthy and out of the hospital can share in the cost of savings they create. Together, these reforms are dramatically strengthening Medicare today for seniors and Americans with disabilities. But we also have the responsibility to preserve the promise of Medicare for future generations. And we can't do that if costs continue to rise unchecked. Because doing care the right way often costs less than doing it the wrong way. Many of the law's reforms are aimed at improving care and reducing Medicare costs. For example, the Partnership for Patients alone, with those two pretty tangible goals, will save Medicare as much as $50 billion over the next 10 years by reducing errors that lead to unnecessary care. But the law doesn't stop there. It also contains important new tools to help stamp out waste, fraud, and abuse in Medicare. For fiscal year 2010, our anti-fraud efforts returned a record $4 billion to taxpayers. And these tools in the Affordable Care Act help us to build on that progress. The Medicare trustees estimate that these reforms in the Affordable Care Act have already extended the solvency of the trust fund until 2024. Without these reforms, the trust fund would have been insolvent just 5 years from now. But when it comes to Medicare's future, we can't take any chances. And that's why the law also creates the Independent Payment Advisory Board, or IPAB, as a backstop, a fail-safe, to ensure Medicare remains solvent for years to come. As you know, the IPAB is made up of 15 health experts, including doctors, other healthcare professionals, employers, economists, and consumer representatives. Members are recommended by Congress, appointed by the President, and confirmed by the Senate. And each year, the board is charged with recommending improvements to Medicare. The recommendations must improve care and help control costs. For example, the board can recommend additional ways for Medicare to reduce medical errors and crack down on waste and fraud. And contrary to what some have suggested, IPAB will not ration care or shift costs to seniors. In fact, the board is specifically forbidden by law from making any recommendations that would ration care, reduce benefits, raise premiums, or raise cost sharing, or alter eligibility for Medicare. It leaves all final decisions in the hands of Congress. If Medicare spending begins to threaten the program's future, IPAB will make recommendations to create the necessary savings without shifting the cost of care to seniors and those with disabilities. But it's up to Congress to decide whether to accept the recommendations or to come up with recommendations of its own to put Medicare spending on a stable, sustainable path. In other words, the IPAB recommendations are only implemented when excessive spending growth is not addressed and no other actions are being taken to bring spending in line. Now, the nonpartisan Congressional Budget Office and the independent Medicare actuary both predict that the IPAB is unlikely to be necessary anytime soon, thanks to the work we're already doing to slow down rising costs. But we can't know about the future, and that's why experts across the country, including independent economists and the Congressional Budget Office, believe that IPAB is a needed safeguard, and we agree. We believe that the best way to strengthen Medicare for today and tomorrow is to fill the gaps in coverage, to crack down on waste and fraud, to bring down the costs of improving care. And that's what we're working to do, given the new tools in the healthcare law. Over the last 16 months, our department has focused on working with Congress and our partners across the country to implement the new law quickly and effectively. And in the coming months, I look forward to working with all of you to continue those efforts and to make sure that Americans can take full advantage of all that the new law has to offer. Thank you again, Mr. Chairman, and I look forward to our conversation.
Thank you. As I mentioned in my opening, I quoted the president, which I thought was pretty much head on with his remarks about Medicare. The trustees, your chief actuary, projects the trust fund goes bankrupt in 2024. CBO tells us it's in 9 years. Do you agree with the president and the Medicare's chief actuary that the status quo as we know it, the traditional fee-for-service system, is unsustainable and will soon fail to deliver the promise of health and retirement security for seniors that we all depend on?
Well, Mr. Chairman, I believe that the fee-for-service system has incentives in all the wrong places.
Right.
So we are often paying for care that actually delivers very poor health results. And in fact, in many cases, if people are sicker, stay in the hospital longer, acquire more affections, are readmitted more frequently, that hospital makes additional money as opposed to preventive, aggressive, home-based, patient-centered care, which often is not only more desirable by the patient and doctor, but actually lowers the cost. So the Affordable Care Act for the first time gives Medicare not only the tools but the direction to actually align the incentives and I think the payment strategies.
Okay, so I think on the premise of that, we would agree, which is the current system is unsustainable and has all the wrong incentives, which is part of the reason why it's driving it toward bankruptcy.
I would say that
Okay,
the
great.
current fee-for-service system, yes, is unsustainable.
So if you could bring up chart 1, please. So here's the question we have. I've got basically 3 questions, and it's basically, how best to solve this problem. According to your chief actuary, providers who are reimbursed through Medicare receive about 80% of what a private plan offers. And as we all know, what inevitably happens is if a provider loses money on a Medicare patient, then they'll overcharge the private payer to make up the difference, and that is putting upward pressure on prices, on healthcare costs. Under the health law of the Affordable Care Act, this falls from 80% to 48% by 2022 and to 33% by 2050. Hospitals suffer the same fate. This is the hospital reimbursement rate curve under the new healthcare law. A 67% drop in prices relative to what private plans pay over the course of the window. So we're already paying them, providers, through Medicare, far less than they get otherwise. In most cases, we're paying them less than the cost of the care. And so I basically have 3 questions. Do you agree that Chief Actuary's findings that cutting payments to providers does have an effect on providers? Because here's what he says. He's saying that by the year 2050, 40% of hospitals, skilled nursing facilities, and home health agencies will have negative margins. In other words, they will go bankrupt. So that means they will leave the business of providing Medicare services to Medicare beneficiaries. Do you agree that cutting payments to providers has an effect on providers in such a way?
Mr. Chairman, I do believe that certainly cutting payment has an impact. What I know is that Medicare cost trends are actually significantly, I would say, better than the private sector, growing at about 4.9% as opposed to the private sector growth of about 7.2% over the last 10 years. And I do believe that Medicare has the opportunity to actually change the cost trends by improving the underlying costs of delivering health care, as opposed to, I would suggest that the House Republican plan just shifts those costs onto seniors and those with disabilities and not addresses the underlying costs at all. I think improving care and lowering costs makes a lot more sense than just shifting costs.
Well, okay, so this is the hospital chart, which shows under the Affordable Care Act, reimbursements to hospitals goes down precipitously. Go to the chart 2 if you can. That's the physician chart, which shows Medicare and Medicaid, obviously, goes down precipitously under what private plans pay. So obviously, if we underpay them, it's going to save more money. The question is if we keep underpaying them at this pace, will they keep delivering the benefit? I mean, so our issue here is if there are fewer providers participating in Medicare because their payments are going down so far below their cost, we have 10,000 baby boomers retiring every day. Do you not agree that if we underpay them, that they'll just stop seeing beneficiaries?
Mr. Chairman, I think that assumption is that nothing changes in care, nothing changes in the care trajectory, that we keep paying at the same not only rates, but keep paying for the same kinds of services. So if you assume that care delivery doesn't change at all, that we keep paying for good care the same as bad care, that we don't have any changes in underlying care, that we don't coordinate care, that we don't have more home-based, patient-based care, that we keep the churning of 1 out of every 5 Medicare patients going in and out of the hospital, whether or not they have seen a health care provider or not, that trend line is probably accurate. I would suggest that what the Affordable Care Act does and what we've begun to do, I think pretty successfully in these early days with the Innovation Center and the very enthusiastic support of a lot of healthcare providers across the country, is look at where the best practices are, where the hospital systems are, and the provider groups who have actually delivered very high quality care well below the trend line, and capture that and then reach out to others to try and accelerate that change and use the enormous payment levers of the Medicare system to do just that, to drive best practices.
So we are right now looking at a law that will pay providers 80 cents on the dollar, then 66 cents on the dollar in this decade, going down to 33 cents on the dollar. So you're saying that we will be able to sort of mastermind how to pay for this care at those low rates, and they'll still provide these services. This is where I don't understand it. Ultimately, don't you believe that there's going to be a time where if you're going to so dramatically underpay for a service to a provider that they would provide to a beneficiary, that they'll just stop providing that service? I mean, isn't that effectively rationing in and of itself? If you don't pay the providers anything close to what it costs to provide the service, won't they just stop providing the service?
Well, Mr. Chairman, again, I would suggest that what is going to occur and is occurring across the country is a different kind of service being provided, a different strategy around healthcare services, and one that actually suggests that doctors and hospitals, through mechanisms like the Accountable Care Organization, actually group together around quality care delivery and share in the savings that they achieve. We have heard from very enthusiastic participants around that strategy. So I think if you capture the status quo and say you just drive that into the future and nothing ever changes, this is probably an accurate chart, but I don't believe that that's sustainable. I also don't believe, Mr. Chairman, that just taking those cost trends, shifting the burden of costs onto seniors and those with disabilities, with which the plan that has been passed by the House of Representatives does, addresses this at all. It just means that more of those costs are going to be paid by seniors and those with disabilities. It doesn't bring more doctors. It doesn't change the underlying costs. It doesn't deliver better care. It means that fewer and fewer seniors out of their own pocket are going to be able to afford the care they need.
Can you bring up chart 3? Okay, so this chart shows you what we thought the prescription drug law was going to cost originally. Actually, the CMS actuary estimated it was going to be about a $700 billion 10-year program. CBO, a $400 billion program. It came in 41% below those cost projections. 41% below the CBO projections, which were $400 billion versus the CMS $700 billion projection. And so I want to ask you basically this. Do you, if you had to do it over again, because at the time there was a debate between Republicans and Democrats about how to do the drug program. The Republican view prevailed at that time, which was to have Medicare certify private plans to offer drug benefits to seniors, and each year they get to choose among competing plans for their benefit. And that active choice and competition, according to your actuary, it accounts for 85% of the cost reductions or the savings from the projection. If you had to do it all over again, would you scrap the Part D program the way it's designed today, and would you have gone with the original point of view that it should just be one program run by Medicare and not one of competing plans?
Mr. Chairman, I don't know that I can answer that question. I think there were a few fatal flaws in Part D that I certainly would go back and change. One was the design of the program so that the seniors who got the most prescriptions fell into a coverage gap. And secondly was it wasn't paid for.
Don't it
So
hold all that
one
stuff
of the
aside,
reasons that
delivery.
Medicare is becoming less solvent is that we have a huge unfunded liability
But the delivery
in
system,
Part
would
D.
you have stuck with multiple plans that people can choose from, or would you have sided with the position at the time of your party that we should not have that and we should just have a one-size-fits-all, only Medicare provides the drug benefit?
As I say, I think there's some fatal flaws that have been corrected. I do think that the drug program is an essential benefit that many, many seniors rely on. I can't tell you the cost estimates of one versus many. I do think Medicare still pays for drugs at a higher price than anyone on
let me ask
earth.
you-
And as a governor who used to run a program where I negotiated for drug prices, I can tell
let me ask
you
it this
it's
way.
still overpaying for drugs.
Should seniors be given a choice of plans to choose from to get their drug benefit?
I think that's a great idea, and seniors are given a choice of Medicare programs now with Medicare Advantage, and many have also some fee-for-service plans along with traditional
Right.
Medicare.
So you agree
What
with-
we know, though, is that Medicare Advantage, the private market strategy, is still well above the fee-for-service strategy, and no beneficial health
Okay.
results as a result.
I don't want to keep wasting time on this, but you agree with the idea that seniors ought to have plans from which to choose from for their benefit. Is that correct?
You tell me what we're looking at and
Part D.
what
I've been
cost
asking
is.
about
I mean,
Part
it's
D the whole time.
impossible to.
I've been asking about Part D. Should they have a choice of plans for their drug benefit?
As opposed to what?
As opposed to the other idea of not having a choice of
If it's 30%
plans.
cheaper with a negotiated rate, probably that doesn't make sense. If it's a choice, I mean, having drug benefits is critical, and I'd like to get seniors the drug benefit
Okay.
at the best possible cost.
Here's the point we're trying to get at here. The health care law, the Affordable Care Act, ends the Medicare guarantee. It ends Medicare as we know it. It takes $500 billion from Medicare to spend on the Affordable Care Act. It puts a cap on Medicare. And this is the first time we've actually capped an entitlement. Now, nobody is arguing against capping spending around here. The only difference is this law empowers the IPAB with the unilateral power to decide how to live underneath that cap. And where we have an issue with, you mentioned affordable care organizations, there isn't a Wisconsin provider that's willing to sign up for this.
Accountable.
The ACOs.
Right.
What our concern is if we invest all of the power and the funding decisions with a board of 15 people whose decisions go into law don't even go through Congress, is that the best way to save this entitlement and to restrain spending? We believe there's a better way, and we believe giving seniors the choice, like we did with Part D, is a better way, because what it does at the end of the day is it shows providers, if you want to succeed, if you want to have business, you got to outcompete other providers for that beneficiary's business. So the nucleus of the program we're trying to talk about is the patient, the beneficiary, not the IPAB. And there is the big difference at the end of the day. We really believe, because of evidence and reality, that giving seniors more choices, where providers, doctors, hospitals, insurance companies compete against each other for that beneficiary's business, that works. More importantly, you talk about what this would do to future seniors. We think we should give more money to low-income people, more money to sick people than to wealthy people in the future of Medicare. And if we do it in a way like we're proposing, you don't have to do all of this to the current population. You don't have to have IPAB start their indiscriminate price controlling in 2013. You don't have to do any of that. You don't have to affect benefits for people above 55, and we can cash flow and borrow the money to cash flow that generation if we reform our generation, those of us under 54. And in the way in which we think we ought to do that, more money for the poor, more money for the sick and the middle income, and less money for the wealthy. It's an idea that used to have bipartisan support. It's an idea that came out of the Clinton 1999 Bipartisan Commission to Save Medicare. It is a very good and legitimate debate to debate about growth rates and how you grow a payment and what should it be, GDP or GDP minus this or that. That's a very fair debate. But at the end of the day, where I think we have a disagreement is we don't think we should invest all of the power and money decisions into the hands of 15 people who aren't even elected versus giving seniors the ultimate decision and controlling how their health care is to be delivered. Because if we just simply give 15 people the ability to unilaterally underpay providers, and we see where this is headed, what's going to end up happening is providers are just going to drop Medicare. I don't know what you call that, but I don't know. It's rationing under a different word. Because if you say to a provider, we're not going to pay you anything close to what it costs to provide this service, they're not going to provide that service.
Well, Mr. Chairman, first of all, IPAB, as you know, in the statute, doesn't come into effect unless Congress has not taken action. So Congress is in the driver's seat. Day one, IPAB makes recommendations. If the spending trends are on target.
It's a supermajority vote to prevent that, though, correct?
Only if Congress has not preceded IPAB. I'm suggesting that if Congress is actually paying attention to the bottom line of Medicare, IPAB is irrelevant, coming up with good strategy suggestions, and it never triggers in. That's step one. I also would suggest, Mr. Chairman, that, when I think about Medicare, I actually start with my dad, who was in the Congress in 1965, sat on the Energy and Commerce Committee, helped to write the law. He turned 90 in March, and I can tell you he's a happy beneficiary, relies on those services, but really doesn't have the capital right now. If he were paying 51 to 70% of his costs, it starts at 61 to 70% of his costs. That is not flexible income that he would have available right now. Third, I think that the notion of moving Medicare from guaranteed benefits, which is what we have said to seniors and those with disabilities, you will have a benefit package that you can rely on into the future. When you get sick, you will not go bankrupt. Turning that over to private insurers and to an unelected group of federal employees who design the benefit package and determine which benefits seniors will and will not get, I am not sure keeps the promise that we made. I am all for looking at strategies to reduce costs, and I would suggest that we've really never done that seriously until the Affordable Care Act. We've never had the tools, and particularly the tools to look at the underlying costs. Not just, trimming off the top of providers, but really re-engineering the delivery of health care. And most a good number of healthcare providers who I visit across the country say not only is it achievable, it's essential, and they're well on their way to doing just that.
Well, I want to wrap it up because I want to get to Mr. Van Hollen and the rest. I've been on Ways and Means for 12 years on the Health Subcommittee. I've watched us try to re-engineer Medicare over and over and over, from Republicans to Democrats. It never ends up working because it's kind of a fatal conceit. We sit in Washington and we think we can figure out how to micromanage 17% of our economy and make this all work, and all we end up doing is artificial price controls across the board. That was what the 1997 budget agreement did, and we had all these providers going out of business, so we put the money back. I don't see how this movie isn't repeating itself.
But if Congress can't figure it out, private insurers are going to then figure out how to...
So we already have private insurers delivering comprehensive Medicare benefits. They've shown that they'll do it cheaper, less than we expected. We already have private insurers providing Medigap, providing Medicare Advantage, providing Part D. Actually, you contract out with private insurers to do Part A. And so that is something we've already had experience with. What we also have experience with is if we simply underpay providers what their costs are, they stop providing. That we have experience with as well. And so I would just simply say at the end of the day, we have a difference of opinion on how best to achieve this. My mom is on Medicare, your dad's on Medicare. They already organize their lives around this program as it's currently designed. Let's leave that alone. Our point is, don't change that for them. IPAB does. We're saying don't do that, but in order to cash flow this commitment that they've already organized their lives around, which we should, you've got to fix it for the next generation, and we just have a difference of opinion on how best to do that. And with that, I'll yield to Mr. Van Hollen.
I know. Thank you, Mr. Chairman, and Madam Secretary, thank you for your testimony. I want to pick up on a couple lines of questioning that the Chairman began, especially as they relate to cost shifting, because that is exactly what the Affordable Care Act addresses in many ways. When you have tens of millions of Americans with no health insurance whatsoever, and they show up at the hospital as their primary care provider, guess who pays? Guess who pays? Taxpayers pay, and consumers pay through cost shifting. Now, we've heard from the chairman about the fact that Medicare actually gets a better deal in terms of the amount of payment to providers, and that is reflected in part in the fact that Medicare's per capita growth rates have been less than in the private sector. That's because they're able to use their bargaining power. What you're seeing with the Affordable Care Act are people who had no health insurance, not a penny. That was cost shifting going on. We were all paying in a big way, and by creating an exchange that tens of millions of Americans can participate in now, they can get their preventative health care. It means they're not showing up in the hospital. So it's not only good for the health of those individuals and their families, but it's good for the pocketbooks of the rest of America, because they were paying zero to the doctors and zero to the hospitals. Now let's talk about another piece of cost shifting, because obviously if you pay doctors zero, you're going to shift costs. Well, if you shift costs the way the Republican plan does, you're not saving a penny to the system. You're just moving those costs onto seniors. I have right here the April 5th, 2011 CBO analysis of the Republican budget plan. It says, right here that under the proposal, most beneficiaries who receive premium support payments would pay more for their health care than if they participated in traditional Medicare under either of CBO's long-term scenarios. CBO estimated that in 2030, a typical 65-year-old would pay 68% of the benchmark under the proposal, compared with 25% under the extended baseline scenario and 30% under the alternative fiscal scenario. I would point out again to my colleagues that is the flip of what members of Congress get in terms of support, a premium, so-called premium support from our plans. Let me just
Carol, you
get
have
my
just
line
a
of questions.
second? Okay.
Sure. Well, let me just, if I could get through this, and then I'm happy to answer questions. So that's the exact flip. That is cost shifting. Doesn't save a penny, and it actually reduces the amount of support. Now, I want, Madam Secretary, you expand upon another point here, which is, as the Chairman mentioned, we already have some private options, private insurance options within the Medicare program. It's called Medicare Advantage. It's called Medicare Part C. And the difference between the current system and what the Republican budget proposes is we allow the Medicare beneficiaries to choose whether they want to go into Part C or whether they want to stay under traditional Medicare. The Republican plan says no more choice. You're forced into the private plans. Now, the chairman mentioned what he described of the benefits of this compensation. Madam Secretary, could you tell us what the rate that the Medicare program was reimbursing the so-called more efficient Medicare Advantage plans compared to the traditional plans before the Affordable Care Act?
Yes, Congressman, the Medicare Advantage plans were being paid at about 113% of fee-for-service, and what the Affordable Care Act directs is that over time, that additional payment, which amounts to about $3.30 per month per beneficiary, not the beneficiaries who've chosen the Medicare Advantage plan, that 25%, but to every beneficiary is paying that additional amount per month every year to keep Medicare Advantage at that artificially high level. So over time, we are directed to reduce that overpayment and put it more in line with Medicare fee-for-service, and we've begun that, and I would suggest still have we anticipate a very robust program, but the overpayment is calculated by the Congressional Budget Office to yield about $140 billion over the next 10 years.
Right. And again, people can choose currently to go down that road. They're not forced to go down that road, as the Republican budget plan would do, but they can choose it. And as you pointed out, we, meaning the taxpayer and the Medicare program, were subsidizing those plans at 114% of fee-for-service, meaning not only were taxpayers paying more for individuals in that plan through Medicare, but other Medicare beneficiaries were cross-subsidizing those plans. Is that correct?
That is correct, and over the period of time, also, there has been a pretty careful analysis of were there additional health benefits that were attributable to the additional expenditure, and the answer is no.
Right. Now, under Medicare Part C, under Medicare Advantage, there's wide range of ability to experiment with copays and premiums and many of the tools that we're talking about. Is that not the case?
There is opportunity, certainly, to experiment and to develop different plan strategies. There are limitations on how much those costs can be shifted onto beneficiaries, and particularly how much the plan design could be used to cherry pick among healthier seniors or sicker seniors. But given those limitations, yes, there's a lot of opportunity for innovative care strategies by the private market.
Okay. Now, I just want to turn to Medicare Part D, the prescription drug plans, and ask you a few questions about that, because it is the case that the expenditures came in under projections. If you read the Medicare actuaries, they point out two major factors there. One was that the cost of prescription drugs in the overall market went down because of competition from generics. And number two, fewer people actually chose to enroll in Medicare Part D than had originally been projected, which of course would bring down the costs. But of course, one of the features of the prescription drug bill, Medicare Part D, when it was passed in 2005, was to deny the Medicare program the ability to negotiate or bargain for drug prices. The other thing that changed that was made was that for people who were so-called dual eligibles, people who were on Medicaid and Medicare, Previously, Medicare, of course, had not covered prescription drugs, but the Medicaid individuals we'd gotten a better rebate, meaning a better deal from the prescription drug companies than when those individuals also got prescription drugs under Medicare. That's money that's lost to the Medicare program, is it not? In other
Yes,
words,
sir.
those are reduced drug prices for the Medicare programs represent savings that could be plowed into the Medicare program and extend the solvency of the program. Is that not correct?
That is correct. And I think in most states around the country, the negotiation of drug prices, formularies, and rebates are something that most governors take seriously with the Medicaid program, and that is not a framework that the Medicare program operates under.
If we go to the fourth slide, and we're going to have the Medicare actuaries here tomorrow, but this is an interesting point that they made in their most recent report, which says the average annual increase in Part D per beneficiary costs are expected to be greater than for HI, that's Part A Medicare, or SMI Part B for the period of 2011 through 2020. So Part D, which as the chairman said, has this competition feature, but where the bargaining for the price of drugs is splintered into subgroups as opposed to being able to get a better deal for the whole group like we do under the Veterans Administration. But what this chart shows is that the Part D is actually expected to grow more per beneficiary than Part A and B. Could you comment on that?
Well, Mr. Chairman, I do think the trends in part are up because there are definitely some more expensive but very significant new drugs on the marketplace, and that will continue to be part of the framework. But I also think that there are some tools that we're still missing. I know in the chairman's home state of Wisconsin, there is a senior care program which was negotiated, put into effect by the governor, is very popular with a lot of seniors in Wisconsin, and still operates as a standalone drug plan, which can be a choice for those seniors. And the cost that Wisconsin seniors pay for senior care is significantly below what Wisconsin seniors can choose from in Medicare Part D. So that we have a real-life example in the state where there is a state negotiated plan and side by side with the Part D multiple choice plans, and the costs are, I would say, significantly different.
Thank you. Well, I'm going to wrap up, Mr. Chairman, with a couple slides. Just if we can go back one slide. What this shows are the projected CBO costs in 2030. And again, recognizing the fact that the Medicare program is able to negotiate better prices and bring down the cost. Madam Secretary, do you know what the average cost for a senior was for health insurance in 1965 before we passed the Medicare program?
The average cost per
the
senior?
sort of the average cost for health care, the distribution of costs borne by the senior compared to the government or other sources.
Well, it's my understanding that first, a number of seniors, a majority of seniors, had no health insurance at all. And secondly, that those who had insurance or some kind of coverage were often paying about 65% of their own costs, and that there was some payment for the remainder.
Right.
At
So
the
some
time
had
of
none
Medicare.
at all, and some
Many
had to
had
bear
none.
the burden that we would go back to under the Republican proposal. If we go back one more slide, this is the 2022 numbers. Again, it's the double whammy. It's the fact that seniors will go into the private insurance market and face higher costs and get less support in 2022, even though immediately the benefit the Secretary talked about with respect to closing the prescription drug donut hole goes away. And then if we can just go to the last slide, this is the Medicare actuary showing how the Affordable Care Act does bend the cost curve. Thank you, Mr. Chairman. Thank you, Madam Secretary.
Congressman, one perspective on those cost issues is if you assume that there are a number of seniors in this country who are living on their Social Security checks, In 2022, the average Social Security check will be a little over $21,000. That beneficiary, with the start of the Republican congressional plan, would be paying 59% of that Social Security check on their health care costs. That same beneficiary today pays about 26% of their Social Security check for health care. So it's a more than doubling what amount of their income would have to go to health care year one.
I want to get to members because we're going to start the clock. One thing we failed miserably on a bipartisan basis is to learn how to manage the thermostat in this room.
Yeah.
God, gee. Tell your actuary who's coming tomorrow
thought
we're
it
going to
was
work
a
on
strategy.
it. So it's,
I
no,
don't
it really isn't. It's that South Carolina temperature
I
we've
just sort of
imported.
keel
You know,
over.
oh gosh, Mr. Price.
Thank you, Mr. Chairman, and welcome, Madam Secretary. We appreciate you joining us today. Many of us, as you well know, and as a physician, have talked about the principles of health care being accessibility and affordability and quality, responsiveness of the system, innovation of the system, and choices for patients. And many of us believe that the new law actually harms every single one of these principles. There's also little trust between patients and folks out there and the federal government as it relates to health care, and for a variety of reasons. Former Speaker Pelosi on this specific law said we've got to pass the law so we know what's in it. And this, the Independent Payment Advisory Board, a denial of care opportunity for the federal government, is one of the things that we now know that's in it. And it ought to be no surprise that there's little trust out there. I will remind you, Madam Secretary, that the original Medicare legislation says in it, and this is still the law of the land, quote, "Nothing in this title shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine or compensation of any officer or employee of any institution, agency, or person providing health care services." Madam Secretary, do you think that we have violated that portion of the previous Medicare law that's still the law of the land?
Violated it by passing the Affordable Care Act? By
having the federal government determine what compensation is provided to those caring for patients.
Congressman, I think that the Medicare from day one determined what compensation they would pay for services, medical services. So I guess I'm not quite sure what we're doing. I mean, perhaps you're suggesting that from the outset, from 1966, it has been in violation.
That we violate that we violate the law, and hence there's little trust on the part of patients. The Independent Payment Advisory Board, this denial of care board, can only do that by denying payment to physicians. In a recent op-ed, you said, quote, "Seniors and taxpayers will have the security of knowing that as skyrocketing costs jeopardize Medicare's future, IPAB is in place to protect Medicare now and for future generations." But in fact, if we talk about the kind of recommendations that IPAB can make, are they able to reach different targets by raising revenue? Can the Independent Payment Advisory Board raise revenue?
No.
No, but not by law. Can the Independent Payment Advisory Board raise beneficiary premiums?
Well, the IPAB, as you know, is prohibited by law.
Correct.
From cost shifting, from premium increases, from denying benefits. I think there are a number of examples of ways that they could have been effective at a much earlier time, and one of them we just discussed, which is the overpayment for Medicare Advantage.
But Madam Secretary, don't you agree?
MedPAC for years.
If I may, because I don't get the kind of time that the chair and the ranking member do. The only way that the Independent Payment Advisory Board are able to affect what the physician does for the patient is to deny payment for that provision of services. Isn't that correct?
I don't think that is at all correct, Congressman. I think they could look at a lot of the underlying rising costs and recommend payment strategies that much more closely align what doctors tell me they really want to do. So medical homes.
But they aren't able to institute any of that. All that they can do is deny care or deny payment to the physician.
I don't think that's the case, Congressman.
Well, I
fundamentally
would
disagree. Medicare Advantage.
I would urge you, Madam Secretary, then to simply read the section. just read the section. And
have.
if I may, this gets to the heart of the quality of health care in this country. As a physician, I can tell you that if I'm told by the federal government that I will not be paid for a service to a physician, what happens in my presentation of the options to that patient as that treating physician is that I may be coerced by the federal government into not even presenting that option to the patient. So this is as pernicious as it could be in terms of the federal government getting involved in the provision of care to patients. And that's what violates the trust that is so important between patients and physicians. And it's why we on this side of the aisle and some on the other side of the aisle feel so strongly that to have a denial of care board in place in federal law is simply a violation of American principles as it relates to health care.
Well, Congressman, I hear what you are saying. I would suggest that the Republican budget proposal, which would eliminate guaranteed benefits for which there will
Madam
be
Secretary, you know
would
that's not
elimin-
true. You know that's not
Mr.
true.
It-
What the
Congressman,
fact
I
of the
think
matter
it
is
is-
that our proposal
carry
guarantees
it over to
the
the next
provision of care for seniors. It
Let's-
guarantees it.
Let's leave it at that. In the interest of time, Ms. Schwartz.
Thank you. Well, I think we'll continue this conversation somewhat. This is important for us to be talking about what are the big contrasts here. And the big contrast, and I'm talking about the future of Medicare, is what we're working on, what passed last year, which is now law, which I want to have you elaborate on, the work of implementing the Affordable Care Act and in strengthening Medicare and getting the best value for our dollars. And I want you to talk about that. But before we get there, to understand the choice that is being presented, the contrast with the Republican plan. We used to call it the Ryan plan, but now that all the Republicans basically voted for it in the House, it is the Republican plan. This is what the House of Representative majority, the Republicans, want to do, which is to end Medicare as we know it, offer seniors premium support. We call it a voucher because they can get to shop in the private marketplace, which, as you pointed out, Madam Secretary, is more expensive and does not have the concerns about costs because they simply can raise the premiums. And the more they raise the premiums, the more seniors will have to pay. Estimates are about $6,000 a year per senior. $6,000 starting, $6,000 per senior per year, going up to doubling that, and who knows what in the future. The cost shift is directly to the seniors with no protections for those seniors, no consumer protections, no guarantees on benefits, and no really offering them, I think what the chairman would say, is options. They can choose between expensive plans or plans that don't have all the benefits they can afford. This is not what we want to see happen. And in contrast, and I will just say this to our Republican colleagues who say that there is no trust in Medicare, most Americans and most seniors like their Medicare, and they want to see it continue, and so do we. So what I think is particularly interesting about what your testimony in this hearing is the very keen focus for seniors in particular about strengthening the benefits and getting better value for the dollars that we spend in Medicare. We know we can do better in delivery of care. And I love some physicians. I actually care a lot about my husband and my son and my daughter-in-law and many of the physicians and hospitals that I know. And they say to me they know they could do better. They would like that flexibility. They would like the tools and the innovations to be able to do that. And the Affordable Care Act, we emphasize primary care. We want to train more primary care physicians. We wanted to pay them better under Medicare and Medicaid. We wanted to give physicians and hospitals real flexibility in redesigning better coordinated care for seniors in this country in order to provide better care, improve their health and their outcomes, and to save taxpayer dollars. So I wanted you to give all that up, to repeal the Accountable Care Act as the Republicans want to, and replace it with a voucher that seniors can use in the private marketplace that has had, unfortunately, not taken these kind of innovative actions the way they might have, but might well now do it in cooperation with what Medicare is doing. Could you just elaborate on particularly the cost savings the potential in cost savings based on the experience that we have already had and the good work that you're doing now particularly in the Innovation Center with accountable care organizations, with patient-centered medical homes, with health innovation zones, with the reduction in hospital-acquired infections and reduced admissions. The opportunity, I understand, is really in the hundreds of billions of dollars in savings. What a better way to use that dollars to be able to reinvest and keep Medicare strong.
Well, Congresswoman, you're absolutely right, and I think we've just started down the path. In addition to the innovations, and I'll talk about those in just a second, I think the new tools that Congress gave us and directed us to use for fraud and abuse are unprecedented. And I think that can yield also some significant dollar savings. We've just started the predictive modeling computer effort, and I can guarantee you it's going to be very impressive in terms of results. But the Innovation Center is just launching some of the strategies. The Partnership for Patients we've talked about, which really is aimed at two simple goals to start with, but many more to follow. That's about $50 billion. That is, according to the CBO, a conservative estimate if we can get more people to participate, lowering hospital infections and preventable readmissions. And that not only helps people in the Medicare system, but anybody who goes into the hospital, if there are fewer infections that people get in the hospital, it's going to help private
Everyone.
Employers. It will help people.
Which the whole point is to
And
reduce the rate of growth in
just to get
costs
that
across
as
the
many members
board.
as possible.
And we certainly will. Thank you.
Is Mr. Chapitz here? No, it's Mr. Stutzman.
Thank you, Mr. Chairman, and thank you, Madam Secretary, for being here today. I want to touch on the progress of IPAB, and the healthcare law provided $15 million in fiscal year 12 to get IPAB up and running. CMS is required to begin calculating the savings targets in 2013. What progress have you made towards setting up the IPAB as a functioning agency?
Congressman, that work has not started. I think the President is consulting with people about possible candidates for the IPAB board, but there is no setting up an agency before there is a board appointed.
Do you know, are there any qualifications to be sitting on the board?
Yes, the statute lays out a series of areas of expertise which the board should have, very similar to what MedPAC board members currently have, healthcare providers, health economists, consumer advocates, people experience with health finance. I think a key difference between the board qualifications for IPAB and the board qualifications for MedPAC are no conflicts of interest if they are to be an appointed member of the Independent Payment Advisory Board. It must be a full-time assignment and not be an active user of the system or receive payment from the system.
So they will sit on, it will be a full-time job, is that
That's the
correct?
way the statute
Any
is
idea
designed.
what salaries would they be paid?
I think it's the same as in, I know it's equivalent of a federal salary, $160,000. I don't know what it's,
Okay, all right.
but it's a level that is a federal, I don't know if it's a federal judge or I don't really know, I'm sorry.
Okay.
Congressman. I can get you that answer.
Could you please elaborate on your claim that this year's House-passed budget, the Republican plan, if fully implemented, would make it so cancer patients would die sooner? Wouldn't a lower quality of care caused by cutting provider payments in half to cause patients to die sooner?
Congressman, I think I was at a hearing where I was asked what happens if someone runs out of money in a voucher in the midst of a chemotherapy program. And I said, frankly, there aren't a lot of options. Charity care is one, donated care is another, or they just stop taking their cancer therapy and would end up.
Well, let me ask this. My
That was my
granddad.
answer.
Okay, my granddad just passed away, and I've seen the how Medicare worked for him. The average couple turning 65 today paid over $109,000 into Medicare over their lifetimes, but they will receive over $343,000 in benefits. As a 34-year-old and many others who are not even close to the age of 65, will I get the same deal?
I think it depends on what Congress decides to do with Medicare in the future.
Could I get the same deal? At the current levels, if we would stick with the Democrat plan, if we would stick with doing nothing, could I get the same deal?
Well, no one has suggested doing nothing, Congressman. I think that the Affordable Care Act actually took a major step for the first time ever in entitlement reform and gave us tools at the Centers for Medicare and Medicaid Services to finally align payment with high-quality, lower-cost care delivery, and we are trying to accelerate that pace.
But what I don't understand is what the Affordable Health Care Plan did was addressed insurance.
No, that's not true. It addresses insurance, but also the care delivery system. It addresses the
So-
underlying system
So do
in
you-
addition to insurance.
Do you believe that health care costs will start declining? Because currently they're roughly at 3 times the rate of inflation.
Well, actually, they have been on a decline. They are right now running lower than inflation. We think that if indeed the strategies are effective where you focus more on preventive care and early intervention, where people are actually healthier as they get to be 60 and 70, you can dramatically improve healthcare costs, as well as some care strategies which are aimed at delivering more patient-centered care out of hospital systems, keeping people in their homes longer, which is what patients tell me they want, and also what a lot of providers would like to do. But right now, the alignment of the payment incentives and the care delivery are not there.
Well, I think that, with these numbers, if $109,000 covers $343,000 in benefits, Americans understand that this is not going to be sustainable over the next
Well, I would agree, and
decade.
everybody
And
agrees with
It's going
that.
to take some big changes.
That's right.
So, thank you. I'll yield back.
Thank you, Mr. Chairman. Madam Secretary, thank you. I would like to just briefly touch a few things, because as I listened to my good friend, the chairman, describe certain things, I wondered if we were talking about the same bill, because certainly you were talking about a very different bill than I heard him talk about. My understanding is that you testified, and I just picked up a copy of it again, in this section, that the provisions here are not triggered by the IPAB unless and until Congress does not deal with escalating costs in Medicare. Is that correct?
That is correct.
That's the bill you're talking about.
That's correct.
And if we fail to act, don't get a spinal implant, then they can make recommendations, and it says right here, and not rationing, not shifting, but in terms of helping in terms of delivery mechanisms, but those go into effect only if Congress has the ability to overturn those provisions. Is that not correct?
That's correct.
That's the bill you're reading.
That's the law.
I listened to my good friend from Georgia talk about what appeared to me to be sort of a fantasy land, because he was concerned that Medicare over the years has had some provisions about Medicare reimbursement. Now, my good friend, as a private physician dealing with private insurance, you've been an insurance commissioner, you're knowledgeable about this. Do physicians just willy-nilly submit anything they want, and insurance companies just pay every provision, every condition, every treatment?
No, rates are negotiated and benefits are very clearly spelled
And
out.
do insurance companies ever push back and deny claims?
Regularly.
They do.
Yes, sir.
Okay, I wanted to get that clear, because I thought that was the case. And so what we're talking about here is just simply being able to have the same sort of provisions that happen in the private sector, except my friends on the Republican side would just turn this all over to insurance companies to do the rationing, the denial, the approval, and seniors will navigate on their own. That's the statement. You don't even have to answer that. I heard you take my good friend Mr. Ryan's point here that somehow the $373 billion cost, which represents less than what was projected, was somehow a grand bargain for Medicare Part D. And you started to point out something in terms of there were other ways of doing it. Could you, I don't want you to do it now, I don't think you should do the math in your head, but I think it's a very serious question. Could you or have some of your certified smart people calculate for us what would have been the cost in 2030 if we just gave our senior citizens the same deal that the veterans get.
We could do that, sir.
I suspect that it's probably quite a bit less
I have
than
a
the
lot of certified smart
$373 billion that my friend is so excited about. Would you think it might be less, the veterans, than what was negotiated?
I think it is substantially less. Yes, sir.
Well, I think it would be good for us to just get those numbers. Because again, I'm concerned that we are talking about a fantasy world where insurance companies don't make decisions denying benefits, don't ration care, don't cut people off, that somehow because the prescription Medicare drug program, unfunded, just sort of launched, was not as expensive as it first projected, that somehow that is a triumph of free market economics, when in fact we could produce much lower costs with systems that the government has, and that we have an actual experiment about the cost effectiveness of this approach with Medicare Advantage. I'm old enough to remember when Medicare Advantage was advanced in the early, because it was going to save money. It was going to be 5% less. 95% on the dollar was the projection. And because the system was gamed or of inefficiencies, it has been 13% more expensive until recently because of the changes that have been put in place to bring it under control. And all the while, seniors are paying a premium. What did you say the extra cost was a month? $3?
I think it's $3.30 per month per beneficiary, and there are about 49 million beneficiaries.
Thank you very much. Thank you, Mr. Chairman.
Thank you. Mr. Ribble. It's my understanding that the Secretary has to go in 10 minutes. So we'll get through this, and then what we'll do is we'll start the members who did not have an opportunity yet to be at top of the queue for the next panel. Mr. Ribble.
Thank you. Madam Secretary, thank you for being here today. I
Glad
know
to
it's
be
probably not the funnest thing you do in your workday.
Certainly the warmest.
Yes, it is the warmest. And it's a warm greeting that we extend.
I appreciate that.
Under the Affordable Health Care Act, I think I understood that we can't deny care. Is that correct? The program is under
Independent Payment Advisory Board.
No, not the Independent Advisory Board, but under the Affordable Health Care Act, the denial of coverage is protected by law. You cannot deny coverage. Is that correct? Can a I get to keep my insurance company, and I get to keep my doctor, and I can't be denied coverage and things like this?
Well, eventually, when there is, in 2014, the health exchange is set up, you will be able to have an ability to come into a market without pre-existing health conditions. Yes, sir.
And once I'm in the market, the health insurance cannot be denied to me if I get sick.
That's correct.
And
You
that's
can't be
done-
dropped.
right, can't be dropped.
Rescissions are against the law. Companies dropping a beneficiary because they made a technical error, because they got sick, you cannot have that.
And that's done through private insurance companies through the exchanges.
That's correct.
Okay, so kind of like the Republican plan for our seniors. Private insurance companies can't be denied coverage, and if they get sick, they get to keep it.
Well, I think a huge change is that the cost sharing is shifted to seniors and those with disabilities under the Republican plan. There is no plan for underlying delivery system changes. There is no fraud and abuse protections, and I have no idea what the benefit package looks like. Maybe there has been a discussion, but at least I have not seen what the $8,000 voucher would purchase in the marketplace.
And so since we can't see all that yet, it just seems a little bit disingenuous for my colleagues on the other side of the aisle and members of the administration to project all these salacious claims about the plan since we haven't yet seen it.
Well, we're projecting costs, and that's not us. It's the Congressional Budget Office, which says that a senior would be paying 61% of his or her costs starting in year one and closer to 70% by year 8. That's the Congressional Budget Office. That's a flip of where we are.
And the CBA shows a large high cost, don't they?
Pardon me?
And the CBO shows a
That's
relatively high
based on
cost by
today's
20.
costs.
Will the
That-
gentleman yield for a moment on that?
Yes.
Just so you know, we asked the CBO about that. They basically said that they can't estimate choice and competition and its effects, so they didn't bother trying. So, number
they
one,
could
they don't
look at
believe
the- they
they-
could
in
look
the
at
efficacy of that
Medicare
number,
Part
they can't
D.
measure it. So,
Very good.
They
Thank
could
you.
look at
I
the
yield
cost
back.
increases in Medicare Part D, and they can certainly look at the cost increases in Medicare Advantage. So we have two
the point is,
real-life
they
examples of
look at the
cost.
example of Medicare Part D and the savings, and they did not replicate that in their cost estimates of this plan. They
Thank-
just ignored it.
Thank you for the clarification, Mr. Chairman. Madam Secretary, during the testimony today regarding IPAP, you said that, not only in your written testimony but in comments, you said that they're prohibited from cost shifting, premium shifting, payment denial, rationing care, raising premiums, reducing benefits, changing eligibility. I think you mentioned that they're going to be paid something for their work. You don't really know how much, but yet you call them a backstop. If they can't do any of these things, what are they backstopping?
Well, let me give you two examples, Congressman, about the kinds of things that, if they had been enacted a lot sooner, I think we could have saved billions of dollars. We just discussed Medicare Advantage, the overpayment which has gone on for decades, and actually the MedPAC group, the group of advisors, has recommended looking at that strategy, lowering it to fee-for-service for years. That has never happened. The other thing that has recently happened, and again, Congress started down this path as long ago as 2003, is our recent experience with competitive bidding for durable medical equipment. It started in 2003. It got a jump start in 2008. It was withdrawn again. This year, we have implemented in one of the Medicare sections, we are saving 32% over the cost we were paying last year for durable medical equipment. There is no change in beneficiary benefits. They are getting the services they need, but at a third the cost. I think those are two kinds of recommendations that don't fall into any of the prohibited categories that could yield billions of dollars.
Okay, thank you very much. And Mr. Chairman, I'm going to yield back to
Great.
give our colleagues a little
Mr.
more
Yarmouth.
time.
Thank you, Mr. Chairman. Secretary Sebelius, nice to see you again. Thank you for your testimony. I want to pursue this line of questioning about competition and the effects of competition, particularly as it relates to healthcare. Doesn't the ability of competition or the potential for competition to reduce costs depend on a fully informed, fully free negotiation on both sides?
Usually, that's what a market strategy is.
And with regard to Medicare Part D, I think certainly virtually everyone had the same experience that I did, that my constituents for a long time were extremely confused, and many still are confused about what their choices are under the prescription drug program. Is that likely, assuming that we were to enact the Republican proposal, that this would be an enormous problem for America's seniors to actually be in a position to intelligently compete with the insurance companies' approach at marketing?
Well, Congressman, what we have done, at least in the last 2 years, in some of the Medicare Part D programs, we've also done it a bit in Medicare Advantage programs, is try to eliminate programs that actually have very little differential, but just add more confusion to the marketplace to do just that. But yes, I think it is not uncomplicated. We used to run a senior Medicare counseling program, and many people want to make the best choices. They often, though, in Part D would find themselves in a program, the drug regimen would change in that program, only to find out that the drugs that they need have actually shifted out of the program. So that is a pretty common phenomena for seniors.
And so then if you add benefits for hospitalization, physician choice, home health care, medical equipment, and potentially hospice and who knows what else, it makes it an extremely even more complicated way for a complicated procedure for a senior to go through, or senior and his or her family to go through.
Well, I definitely think that, there is a huge ongoing effort to educate folks about what the benefits are and how to take the best advantage of them. one of the points we haven't really touched on, but I do want to mention is just the additional cost of administration. Most insurance companies, even the most efficient ones, run at about 11 to 13%. Some are as high as 25%. Medicare has about 2% or less administrative costs. So assuming you have X amount of dollars, a fixed contribution, whatever that fixed contribution can buy in health benefits, less of it is going to go pay for health services in the private market than in the public market.
And granted that the Republican proposal has not been put into legislative language that we could actually look at, but if you consider the statements that have been made from the other side that nobody can be turned down, that nobody can be denied service, that nobody can be denied the choice of the physician under the Republican plan, do those stipulations make it much more difficult for insurance companies then to actually lower costs?
Well, again, insurance companies, to my knowledge, have a network of doctors. So they do accept some and deny some on a regular basis. They negotiate with hospitals. Some are in, some are out. They negotiate with drug companies. I mean, that's part of the strategy to put a plan together. And then when you buy that insurance, you are buying basically that network, that hospital system, that group of providers. It's, I think, a different system than Medicare currently, which says to a patient, you can choose any doctor you want. If you don't like this doctor, you can go to a different doctor. That is not the strategy around private insurance.
But I guess what I was trying to get at, judging from what's been said from the other side about the Republican proposal, is it likely that they could have a significant impact on overall costs to the system if they can't deny care, they can't deny anyone coverage, and they can't, and they have to provide all the services that Medicare provides?
Well, if you assume that insurance is about selling a product which delivers health care, pays providers, pays hospitals, pays doctors, there are only a limited number of ways that you can reduce costs. You can reduce administrative costs. You can negotiate better prices with all the payers and providers, which is reducing costs. You can aim at better health strategies, which I think can be effective, get a healthier population. I think often in the private market currently that's done by cherry picking. We take healthier people and deny sicker people, so the pool is healthier. You make money that way. But there are a limited number of strategies. Or you can shift costs. And I would say that both the Medicare and Medicaid proposal that passed the House shift costs onto seniors, those with disabilities, onto states.
Thank you. Madam Secretary, I wish we had more time to get into all of this. I obviously have a strong difference of opinion of your interpretation of what we're doing, but I don't think you like our interpretation of what you're doing. This is an issue we're going to have to get into in much more detail. It affects nothing more than the health security of our nation's seniors. We have a strong difference of opinion on who ought to be in charge of their health care, them or this board. I wish we had more time to get into it. The members who have not yet had the opportunity to ask will be front of the line for the next panel. And with that, Madam Secretary, I know it was a hot morning. Thank you for your indulgence. I appreciate it and hope we can do this again.
Thank you, Mr. Chairman.
Thank you. Next, we'll hear from our next panel. If the panel can proceed to the dais. Where's the... Is it Fetter? Go ahead and have your seats so we can get started. Aren't there name tags up there? Oh, Jose's putting your name tags there. Yeah. Shh. So our second panel consists of former CBO Director Doug Holtz-Eakin, Grace Marie Turner of the Galen Institute, and Judith Feder. Is it Feder? It's Fader. Fader, thank you. It's one of the two. Judith Fader of the Urban Institute. Because we have votes, it looks like at about 1:20, we're going to stick to the 5-minute rule for our panelists. So if you could confine your opening remarks to 5 minutes, and then we'll do the questioning, as I mentioned earlier. And if there are additional points that the panelists want to interject, they can do so during the questioning. Let's start with you, Mr. Holtz-Eakin, and then we'll work our way from our right to left, your left to right. Thank you. Mr. Holtz-Eakin.
Thank you, Chairman Ryan, Ranking Member Schwartz, I gather, members of the committee. It's always a good day to be back at the Budget Committee. And you have my written testimony. I won't belabor the points there. There are 4 simple points I think ought to be made. The first is that, to my eye, the IPAB is a policy error, and one that the Congress should reverse as quickly as possible. It is likely to exacerbate existing reimbursement problems for providers in the Medicare system, and as a result, impede access by Medicare beneficiaries. It is likely to stifle innovation. The incentives are such that it will target the most innovative and newest therapies, and that the IPAB, as part of the status quo for Medicare, is dangerous to beneficiaries, dangerous to the federal budget, and dangerous ultimately to our economy, because it is part and parcel of a broken social safety net system whose spending threatens to drive debt to levels which would harm the U.S. ability to compete and grow. Let me expand on those only briefly and then turn it over to questions. The structure of the IPAB is such that it is likely to exacerbate the reimbursement problems. I mean, the way the statute is written, much of Medicare spending is off limits, so it's likely the board is likely to have to target something that looks like less than half of the total spending, and thus disproportionate efforts would be focused on that. The IPAB's given 1-year targets. It says you've got to get things under control in a year. There aren't many levers you can pull from a proactive quality of care or value proposition that you can do on a 1-year basis, and in the end, they'll start cutting provider reimbursements. It's something we've seen before with the SGR. It's something we'll see again. And we know vividly from the Medicaid program, where reimbursements are just a bit over half of private payers, that beneficiaries have a great deal of difficulty getting access. That would be the future of Medicare as well, more broadly. We've seen, for example, with past episodes and cuts to the physicians under the Medicare program and the SGR, that fully 2/3 of practices have contemplated changes in their access for Medicare beneficiaries, whether they take new patients or not. So I think that's an outlook under the status quo that is dangerous for beneficiaries and dangerous for the American healthcare system. It is quite likely to stifle innovation. We know at some fundamental level that innovation is at the core of the ability of the United States to solve its pressing problems in healthcare, in energy, in education, and a variety of policy areas. Given that there will be a mandate to cut spending, the most likely targets are those new therapies, the ones that are just introduced into the market. They've been expensive to develop. They have not yet reached economies of scale. These are going to be the newest, most innovative approaches to things like Alzheimer's and the problems that face us, and the IPAB will have a disproportionate incentive to stifle those. From the perspective of someone who's developing new therapies, the IPAB's a tax on the return to these, that you're not going to get a return on your investment, and worse, it's a random tax. You don't know when it's actually going to pop up and grab the return to your investment. So it'll have terrible incentives for the development of new medical science in the United States, and as a result, harm the future quality of care. And then it is part, this focus on trying to cut provider payments and control a broken fee-for-service Medicare system is part and parcel of a status quo that I think we simply have to change in a fundamental way. We know that these important social safety net programs, Social Security, in red ink, unlikely to survive to the next generation. Medicare, enormous buckets of red ink, $280 billion a year in general revenue flowing in, not going to be to survive for the seniors of the next generation. Medicaid, the future deserving poor will be unable to receive its services. And in the process, they are feeding the deficit problems that this Congress has to grapple with and the Budget Committee is so well aware of. And we know that ultimately that's not simply a budgetary issue, that's an economic threat of the first order. Erskine Bowles, co-chairman of the President's Fiscal Reform Commission, called it the most predictable crisis in history. So the issues that are before us today are whether we will take a policy approach which has led to us being on the precipice of a disaster, or whether we will fundamentally change the structure of the Medicare program and the social safety net. And I would encourage this committee and the Congress as a whole to take the latter approach and to discard this policy error. Thank you.
Thank you, and within 12 seconds. Great. Ms. Grace Marie Turner.
Thank you, Mr. Chairman, Mr. Van Hollen, members of the committee. There's no question that Medicare spending must be constrained if we're going to have any hope of getting overall federal spending under control. But clearly there is a wide diversity of opinion about the wisdom of using the Independent Payment Advisory Board as a tool. It was designed to take difficult decisions about Medicare payment reductions out of the hands of consumers and legislators and delegate them to this panel of 15 independent authorities. But the Constitution gives the power of the purse to Congress so that elected representatives can be accountable to the voters in their decisions. The IPAB would turn this principle upside down. The unelected IPAB members will ultimately determine spending policies that will determine whether millions of seniors have access to the care they need. This challenges the very principle of representative democracy and the consent of the governed. The IPAB is at the center of a conflict between two worldviews. Do we entrust doctors and patients with decisions, or do we entrust those decisions to a government-appointed panel of experts in Washington who will have authority over hundreds of billions of dollars in Medicare spending? The government approach to holding down Medicare spending traditionally defaults to making deeper and deeper reductions in payment rates to providers rather than implementing reforms that reward innovation. The legislation is true to form. And perhaps during the question and answer we can talk a little bit about some of the government's experiments so far in innovation and how those have turned out. Because of the directives written into the law, reductions achieved by IPAB between 2013 and 2020 are likely to be limited primarily to Medicare Advantage and to Part D prescription drug program and to skilled nursing facility services. If the board is forced to reduce overall Medicare spending by focusing only on these relatively smaller segments, the cuts would have to be very deep to achieve overall per capita spending reductions. Because any of these moves could have major repercussions on access to care, it would seem that seniors and taxpayers would be much better served if these changes were to be openly debated through the legislative process rather than imposed by unelected officials. Even before the IPAB cuts began, Medicare actuaries found that large reductions in Medicare payment rates already built into law would likely have serious implications for beneficiary access to care, as the chairman described in his opening remarks. The president would double down on these savings by giving the IPAB even more authority to cut payments to achieve his deficit reduction goals. It's hard to justify further cuts in Medicare provider payments. Skip a little bit. Clearly the repeal is the best solution to begin to get us on a chart, on a path that can move toward a 21st century health sector. Part D shows us the way. We have a working model that shows that when private companies compete, and importantly, when seniors choose, that you can get costs and spending down both for seniors and for taxpayers. The average monthly beneficiary premium for Part D coverage will be $30 in 2011, far below the $53 a month forecast originally. 84% of Part D enrollees are satisfied with their coverage, and 95% say their coverage works well. But looking beyond IPAB and looking beyond Part D, Chairman Ryan has proposed a comprehensive plan to modernize Medicare that builds on the Part D model. The key is premium support, which provides seniors with an annual subsidy to purchase a guaranteed Medicare health plan. When it begins in 2022, seniors would receive an age-adjusted allocation so they can pick the health plan that meets their needs, just as 11 million seniors already have done voluntarily through Medicare Advantage. Premium support allows for flexible subsidies that can be adjusted and targeted to seniors based upon their age, financial well-being, health status, and similar considerations. To survive, Medicare must be changed. And the question is whether it will be under IPAB and the rationing built in the President's healthcare law, or through Chairman Ryan's plan that provides a path to sustainability for Medicare. It's a clear choice between this and the top-down approach that puts a small number of independent experts in charge of decisions that will impact tens of millions of seniors and progressively limit their access to care. Thank you, Mr. Chairman.
Thank you, Dr. Fader.
Thank you, Mr. Chairman. Ms. George, members of the committee, I'm pleased. Oh, sure. How are we doing? Got it. Now, thank you, Mr. Chairman. And Ms. Schwartz and members of the committee, glad to be with you today to discuss the role of IPAB, which I believe serves as a guarantor of the ACA, the Affordable Care Act's investment in assuring all Americans quality care at lower cost. As you consider the role of IPAB, I call your attention to the fact that Medicare is an enormously successful program, more successful than private insurance in pooling risk and controlling costs. Medicare has historically achieved slower spending growth than private insurance, and the ACA extends its relative advantage. Action taken in the Affordable Care Act produces an average annual growth rate of 2.8% per Medicare beneficiary for the years 2010 to 2021, 3 percentage points lower than national health care spending. National health spending is projected to grow about 2 percentage points faster than GDP growth per capita, and Medicare's projected per beneficiary spending growth will be a full percentage point slower than per capita GDP. Growing slower than the private sector is good, but not good enough, since both the public and private sector are paying too much for too many services and failing to assure efficiently delivered quality care. That's why the Affordable Care Act goes beyond tightening fee-for-service payments to pursue a strategy of payment and delivery reform and creates the IPAB to assure effective results. The strategy includes payment reductions for overpriced or undesirable behavior and bonuses or rewards for good behavior, most especially through payment innovations that reward providers for coordinated integrated care efficiently delivered. These reforms have the potential to transform both Medicare and, by example and in partnership, the nation's healthcare delivery system to provide better quality care at lower costs. I've been kind of amazed to hear how little confidence there is in the capacity to reform the overall system, and what the achievement of these savings cannot be assumed. That's why the IPAB exists, to recommend ways to achieve specified reductions in Medicare spending by changing the way Medicare pays health care providers. In essence, IPAB serves to inform and assure congressional action to keep Medicare spending under control. Now, we know that some have proposed repealing the IPAB, but along with about 100 health policy experts who recently wrote congressional leaders in support of IPAB, I see that effort as sorely misguided. As we wrote, the IPAB enables Congress to mobilize the expertise of professionals to assemble evidence and to assure that the Medicare program acts on the lessons of payment and delivery innovation the Affordable Care Act seeks to promote. I would contrast the ACA strategy to strengthen Medicare with the alternative strategy, not only to repeal IPAB, but also to eliminate Medicare for future beneficiaries, replacing it with vouchers for the purchase of private insurance. Vouchers, I would call to your attention, that are set taking into account all of the reductions in Medicare payment that we've heard criticized this morning. The CBO analysis shows that such an act would not slow healthcare cost growth. It would increase costs, the cost of insurance, and shift responsibility for paying most of them onto seniors. Given Medicare's track record relative to private insurance in delivering benefits and controlling costs, morphing Medicare into the private insurance market simply makes no sense. Rather than go in that direction, what we should recognize is that Medicare is clearly doing its part to control costs having reduced spending per beneficiary considerably and well below that in the private sector. But it can only go so far, as you've noted, on its own to promote efficiencies without partnership with the private sector. Healthcare spending growth is not fundamentally a Medicare problem. It's a healthcare system problem. Effective payment and delivery reform requires an all-payer partnership to assure that providers actually change their behavior, that we don't go on as we've gone, rather than looking to favor some patients over others or to pit one payer against another. Rather than moving to abandon IPAB, which supports Medicare's continued and improved efficiency, I urge you to modify IPAB's current spending target to apply not just to Medicare, but to private insurance, indeed all healthcare spending, and extend its authorities to trigger recommendations for all payer payment reform if the target is breached. It's all payers promoting efficiently that the nation very much needs.
Dr. Fader, I appreciate that very pure statement.
Well, and I appreciate your appreciation, Mr. Chairman.
With that, we're starting with Mr. Flores.
Thank you, Mr. Chairman, and I would like to thank the panel for joining us today. I believe IPAB has a fatal flaw built into it, but before we do that, I'm going to try to hit some questions quickly. Dr. Holtz-Eakin, you started your comments talking about the insolvency of Medicare and Medicaid. Can you give me what your perception of those metrics is? If you looked at Medicare and Medicaid
moment,
as is a private sector pension plan.
We know that Part A of Medicare is running a cash flow deficit right now. Parts B, C, D were never set up to be on their own footing, so they've always counted on what looks to be 75% general revenue. So we have something well over $250 billion, probably close to $280 billion flowing in out of general revenue to keep the program alive. That's now, and it's going to get worse.
Infinite time frame.
It's infinitely
my
large.
My understanding is that Medicare is insolvent to the tune of about $60 trillion. Is that about right?
So these are games that budgeteers play, but let me give you the sad fact. Medicare grows so quickly that there is no interest rate from which you can actually do a discounting exercise that will cause it to converge. So it is infinitely underfunded by any sensible piece of arithmetic. You can only get a number.
So more than $60 trillion.
You can only get a number if you assume a miracle occurs somewhere in the future and healthcare costs grow more slowly.
Right. Well, we're going to get to that in just a second. And Medicaid is somewhere in the neighborhood of $15 to $20 trillion, right?
Yeah.
And those numbers together are 5 times our current national debt.
Huge.
Okay. One of my very first economics professors taught me that the laws of economics are like the laws of gravity. The worse you violate them, the harder the impact at the end. And that's essentially what we're in right now. If you look at what has been claimed to be the benefits of IPAB, it says that we can cut costs to providers, but yet not ration health care. So my question for Secretary Sebelius was going to be, if we cut the budget for HHS by 2/3, would she still continue to be able to provide the quality response to her missionary requirements? And I would assume her answer would have been no. My next question to her would have been, if we were to cut the pay for the typical HHS employee by 2/3, how many young people would want to enter that profession? And so I'll ask whichever person on the panel was asking, we cut the pay for doctors by 2/3. How many young people, as they're going into college, are going to make the decision to go pre-med and then to follow through all the way through their residency program and to become doctors? Anybody want to answer that?
I don't know the number, but the incentives are clear. And we've seen this movie before. I mean, we've been through this exercise where we say to beneficiaries, you can have all the medical science you want at low or no cost, and then it costs an enormous amount. So we go to the providers and say, no, stop that. Either literally don't cover that service or we'll cut the reimbursement.
And the same thing's going to happen in the technology area
and
where we improve Medicare through technology.
Mistake. It's the same mistake.
Right.
May I
Okay, there's going to be
respond?
less investment in the industry because there's less money going into the industry to go forward. One of the things that's caused one of the claims that's been made by government, by Madam Secretary, was that Medicare's costs have grown at a rate slower than that of the private insurance market. And I can tell you firsthand, as somebody that was in business for 30 years before I came here, the reason for that is we began to clamp down on what government health care plans would provide, and all of those costs shifted to the private sector. Does anybody disagree with that?
No.
Yes.
I was there.
Well,
I
so
watched my
I.
premium increases go up every year. So where did this go? I mean, what caused it on the private sector?
The private sector has been far less aggressive than Medicare in attempting to limit healthcare costs. It is
So the government
and they
invented the
relied on-
HMO or the
They
PPO?
relied on actually, the government did invent the HMO in the 70s in the Reagan administration. They actually promoted that policy, and they developed from that point. That's
Let me
correct.
correct you, though. It came from the private sector. So I don't see how we're going to make this work. We're going to cut pay to the people that provide medical care by 2/3, and we're going to expect them to stay in the business.
May I comment on that?
Sure.
As I said in my testimony, what I think is there's an assumption that the medical care system stays the same as it is, that there's no way to improve productivity in the system. The healthcare industry is the only sector in which we've not seen productivity increases. And in fact, and I see the chairman nodding, the capacity to achieve productivity increases by delivering healthcare more efficiently, getting rid of unnecessary readmissions, being a primary example, is out there as a strategy that we all need to pursue and is being pursued by the public is leading, private payers are doing it as well.
We'll let that continue because I just want to get to everybody. Mr. Pasquarello.
Thank you.
Thank you, Mr. Chairman. And to add to what the good doctor just said, there were and are 3 promising models to cut costs and improve quality. If you don't believe in that, then you don't believe in the reform that was passed. And one is the accountable care organizations. You've heard those terms. You've heard the discussions about that. Value-based purchasing programs. Very few places have done that. Where it's been done, it's been successful. And payment bundling, which is very, very critical. A lot of places don't want to do that, do they, doctor? So there are many sections, Section 301 to Section 3009, and Section 3020 to Section 3028 deal very specifically with some things that were not scored by CBO, which I believe are going to bring tremendous amount of... Look, when it comes down to it, doctor, here's where we're at. Democrats want a guarantee benefit program. The other side does not. Regardless of how you slice it, that's what it comes down to. They're entitled to their opinion. I say that with deep respect. But I want to talk about rationing. Rationing. Heard that term. It came out the first couple of weeks when we started to discuss health care reform. We want to ration. You know, that's when it led to those cryptic remarks about we want to push Aunt Tilly off the cliff so we don't have to pay attention to her anymore. So let's talk about rationing, Mr. Chairman. Over 50 million people in our country are uninsured. Kaiser Foundation, I think, has given us some good figures on that. 25 million are underinsured. And we see that in the day. The letters I get, the calls I get in my congressional office, I'm sure the other guys and gals do the same thing. People cannot afford the care that they deserve and need. They can't do it. Rationing. As you all know, 2/3 of all personal bankruptcies are due to health problems. Rationing. Just because you have insurance doesn't mean you're covered. We all know that, right? You could get diagnosed with the disease, your doctor could prescribe a comprehensive treatment for you, but if your insurance company says no, what do? Well, you can call your congressman. You have little power against the insurance company. And that's what this is all about, doctor. Don't kid yourself. Just look at all the requests that we get. Am I correct? Let me ask you, Ms. Turner. Am I correct that this kind of rationing exists under private plans?
People are making choices and decisions all the time about limited resources, both in their financial capacity as well as the capacity of the market to deliver.
You can make a choice if you can afford it, if you're given the ability to make that choice. Not everybody can make the choice unless there are options in front of you.
But
and
market-
options that you fit into. And you don't have to worry about the person who's offering the options saying, you don't qualify, or you have this disease and we're not going to cover you. Isn't that rationing?
We have,
Isn't that rationing?
we do not have a functioning market in our health sector.
Mr. Chairman,
People
is
should
that
have
rationing?
more choices.
Thank you.
And the market
Is that-
would
is that-
provide those
Is that
choices.
rationing, Mr. Chairman?
Does the gentleman want
gave the
to, does
question
the
up.
gentleman want to yield his time? I think let's try and get decorum.
Yeah.
Having the government deny care to seniors through providers, I would count as rationing.
Okay. Would you agree with that, Ms. Turner?
Having the government deny care to seniors through payment policy would also be rationing, yes, sir.
How about if insurance companies deny care and coverage to a young couple 40 years of age with 3 children?
Absolutely, and we need to reform the system so they have more choices and own that insurance.
Thank you.
So they can make their own choices in a competitive marketplace.
Thank you, thank you. It's all choices, but if you have choices out there, real choices. I yield back, Mr. Chairman.
Okay, just for the last 14, I would simply say at least you can fire your insurance company. If you only have the government providing your benefit, you can't fire your government.
If you have someone else to take the place of that insurance company, yes. If you don't,
That's why we got to fix this problem. We got
Well-
to fix the insurance market.
well,
We
the
got to fix the
Healthcare
healthcare
Reform
system.
Act is going to do that, Mr. Chairman.
We respectfully disagree. Next, we have Mr. Mulvaney.
Thank you, Mr. Chairman. As a limited government conservative, it's sort of hard to even know where to start to look at the Health Care Act. I heard Mrs. Sebelius in her testimony just a few minutes ago talk about where she starts when she looks at it, and she said she starts with her father, and that got me to thinking about where I start, which is I start with I have 3 6th graders. And as I listen to the list of everything that has supposedly happened, all these wonderful things that have happened so far, we've had this magical $250 check go out to all of the seniors right before the election. We had this 50% discount now on name brand drugs. We've got free annual wellness checkups. All I could think of as she was listing those things was who's paying for it, because it's my kids. That probably drives my inquiry here. And I think it's interesting that these 3 6th graders have started to read a little bit of Orwell. They've read Animal Farm. They're getting ready to read 1984. And it struck me in Mrs. Sebelius' testimony that she used some words that I think mean different things to different people. She talked about the IPAB, which you all have talked about, as a backstop or a fail-safe. And I have no idea what that means. I think I know what it might mean. What I think it means is that it is a committee that is set up to do what the administration wants to do if Congress won't do it on their own. And all of her testimony, I think, was partially correct when it came to the IPAB. You heard her talk about the process, about the IPAB would make recommendations on the growth rates, but that the final decision would go to Congress. Maybe, not exactly true. In fact, what she didn't say was that IPAB would make the recommendations, and unless Congress either approved that or came up with another way to save the same amount of money or have the same amount of impact, those recommendations would become law. Those recommendations would become law. In fact, if all of Congress got together and unanimously, Republicans and Democrats said, we don't want to do what this board just did, that recommendation would still become law. She also accurately said a part of what the IPAB cannot do. You heard Mr. Pascrell just a few minutes ago talk about the fact that the IPAB is prevented from rationing. They're also prevented from making recommendations to to reduce services or deny coverage or that type of thing. But here's what they can do. They can, as Mr. Holtz-Eakin suggested, they can recommend reductions in payment for services. In fact, it's one of their primary tools. And this example, while an extreme example, is entirely legal under the law. The IPAB could come out and say, as of next year, the reimbursement rate for a knee replacement is $1. And that's going to save X number of dollars. And unless Congress comes up with a different way to save that $1, then that becomes the law. That becomes the reimbursement rate for knee replacements. And in the event that happens, and doctors stop providing knee replacements for $1, then I think there would be a reduction in services. It's interesting, I think, to Mr. Pascrell's point, in the bill, the law goes out of its way to make sure that a recommendation to reduce reimbursements, to reduce payments,
is not to be deemed rationing. So the IPAB is given the ability to lower those payments, even though it has the effect of rationing coverage. And I see that Mrs. Fader is disagreeing with me. I will tell you that we talked to CRS actually about that example, and it turns out that it's absolutely right. So here's what we've got. We've got this board that's in charge of innovation. And I'm getting to my question, Ms. Fader, and so I'll leave it to you. We've got this board that's in charge of innovation. We've got this board that is going to be in charge, or could easily be in charge, of up to 20% of our economy. So my question is this: can someone please, and you get the first chance, give me an example of where that has ever worked in the history of mankind?
Do it again. I think that we rely on independent boards which have varied records. We rely on a Federal Reserve to manage the banking system. We've got some ups and downs with that one of late. We rely on an Interstate Commerce Commission. We rely on a number of commissions.
Does the Interstate Commerce Commission have the right to make law without Congress's approval?
I don't think so, but I'm thinking that if I go to you with the Fed makes a lot of rules for the banking system, so let me stay there. And what I think is important here, and I do disagree with some of the aspects, I think that some of what you said was not quite accurate, because Congress, if everybody in Congress doesn't like the recommendations, they can reject them. That is
only if they come up with another alternative that saves the amount of money.
60 votes in the Senate can reject it.
But let me stay on your point then. So what you're offering...
Could I
Sure.
just finish? My point is that what I believe that the board does for the Congress is give you a source of expertise and tee up the issues that need to be addressed. And I think that Secretary Sebelius gave us examples of the kinds of things they could do, whether it's they could promote a patient safety initiative, they could promote better payments, more efficient payments. So I think that there is a tremendous good they can do in bringing expertise to the Congress.
Ms. Fader, we'll have to leave it at that. Ms. Moore.
Thank you so much, Mr. Chairman. I am a little bit interested, Mr. Holtz-Eakin, in this miracle that you were talking about in terms of reducing the trillions of dollars in liability that Medicare faces. And I do agree with you that there is an unfunded liability. And how you might reconcile this. You say that you stipulate that health care costs in general, not just in Medicare, must grow more slowly, which is something I've been harping on continuously. It's not just Medicare, it's the larger health care costs that must grow. But you say that the IPAB is dangerous, that it will stifle innovation, and, so I guess your suggestion is that we shouldn't limit the cost in the growth of innovation, that would be, and we do need innovation, and the IPAB targets that. And many of us allege that, yes, this huge gap between the cost of innovation and all that will be borne by seniors, that this trillions of dollars, if you would support, for example, the Republican plan for Medicare, would target seniors. So I'm asking you to respond to how you see us limiting the cost of health care and also maintaining the innovation. I'm a little bit more interested in the miracle.
So I think fundamentally that the key defect of federal health programs, Medicare and Medicaid in particular, Affordable Care Act will be this way, is that they don't impose any budget on those programs whatsoever. They are open-ended draws on the taxpayer with little incentive for useful adoption of innovations, efficiency and coordination of care, or any of the things that everyone recognizes would improve the American healthcare system. And so I'm cognizant
so to
that
some
there's
extent,
a vigorous
you're
debate.
agreeing with the Affordable Care Act reforms in terms of...
It doesn't do any of the things. There's no budget constraint put on anything here. All it does is say, again, as we've done in the past.
Budget restraint, though, you're not wanting to restrain innovation.
No.
So the restraint would come where?
So
From where?
I realize there's a vigorous debate, both sides of this committee, about the House-passed budget. But among the things that a premium support plan would do is it would cap the taxpayer's liability.
The taxpayers, but not the patient, who are also, they're not taxpayers anymore because they're retired.
Step one, we both know that fundamentally, to be successful, healthcare costs must grow more slowly. We must stop the
Okay, so
overuse
thank
and
you.
underuse.
So I'm just, I'm hearing you say that these trillions of dollars have to be paid for by folks who are no longer taxpayers, they're retired. Let me
That's
ask
not what
you,
I said, for the
well,
record.
that's what it sounds like. I'll ask Dr. Fader. We heard Secretary Sebelius, we heard the actuary, was it the CMS actuary, Mr. Chairman, say that the Affordable Care Act reforms could generate savings, but he was skeptical that there was the political will to execute them. I'm wondering if you think that the IPAB would be an enforcement mechanism that might, he stipulates that we could recognize savings if there were an enforcement mechanism.
Well, thank you, Congresswoman. What I indicated in my testimony is that I think that what the IPAB does, it acts as a backstop or guarantor to make sure that the innovations that are in the Affordable Care Act, that we are, many of them, untested and just under development, which may have been what the actuary was talking about, those actually take place, or that the improvements, the demands or accountability for improved productivity for providers, which may have been what he was referring to.
Yeah, I want to give
actually
you another
take
chance. I
place.
want you to help Mr. Holtz-Eakin out because he says that I mischaracterized what he was saying. Can you guys are all experts in healthcare and I'm not. I was interested in the miracle of paying for these higher healthcare costs without sticking it on seniors. And so he talked about needing innovation and yet, and not stifling innovation, but slowing the growth of healthcare. How would you?
Well, I'm not sure what he meant, and I'm sure Mr. Holtz-Eakin can speak for himself, as I have heard him do. But what I believe is that the innovation that moves us away from a payment system that continues to reward for ever more expensive services without regard to benefits for health needs to be replaced with an accountable system that rewards providers for delivering quality care, actually pays docs better.
And not
I
death
believe that's
panels,
the
right?
innovation. By no means death panels. We never have been and are not talking
Okay,
about
I just want to use my last 6 seconds by saying I want innovation. I want new technologies available to seniors, but I do think that there has to be some shared payment for the system and not to pass trillions of dollars of
Onto
costs
them.
onto
Thank you.
retired seniors.
That's
Thank
right.
you, Mr.
Ms.
Chair, for
Ms.
your
Black.
indulgence.
Thank you, Mr. Chairman. And having been a nurse for over 40 years and being in the healthcare system, I think there are a lot of things that we could do to reform healthcare, and we had a great chance to do that, and we missed our chance. But let me go back to IPAB, because as an elected official and also someone who believes in the Constitution, I believe that this IPAB is a very, very serious breach in what Congress should have the authority to do. So there's unprecedented power here to an unelected board. And I really believe that it is misnamed because it says it's an independent payment advisory board, but it's not just advisory. It has muscle, it has strength. And where I have the concern about this is currently the law says that the Independent Payment Advisory Board will kick in with its recommendations looking at Medicare growth at GDP plus 1%. The president has also come out and said that he believes that we need to lower that even to 0.5%. Secretary Sebelius was here just a bit ago, and she made a great deal of emphasis on the fact that Congress has the ability to be able to make these recommendations before the board kicks in. But let me go to why I think that's a really misinformation piece, is that currently GDP is growing at somewhere between 3 to 4%. And I think I'm right on that. Medicare is around 7%. And if we've got such a low threshold of saying GDP plus 1%, IPAB's going to kick in pretty quickly. And when they kick in and they give these so-called recommendations, they're not just recommendations. From my understanding is that they are indeed going to be law or made changes to the way we currently operate unless there's a 2/3 override, which is a very, very high standard, and we all know how difficult it is to get 2/3 for anything unless it's naming a post office. So I have a real problem with that, in addition to the problem with transparency and how this board is going to operate behind closed doors without public opinion, public comment, and so on. What I'd like to hear from each of the members of the panel here is, do you believe that there is a constitutional problem with having a board making decisions that are going to become law without them being elected officials?
I am not a constitutional lawyer, but I do think it is at odds with conventional congressional practice and allocation responsibility and oversight. And I find it troubling from that perspective alone. I'm also a bit mystified by some of the other discussion about it. So there's been the notion that somehow it's just a bunch of smart people who will give ideas for payment systems reform to the Congress, and then you guys will take care of it. There exists such a group. It's called MedPAC. I served on MedPAC. It's where they send old CBO directors to die. And if it's just a matter of advice, this brings nothing new to the table and thus will replicate the failure of MedPAC. There's also the notion that it guarantees other successes in the bill. That's not true. I mean, let us stipulate for a moment that the Center for Innovation at CMS will actually do something. I'm skeptical, but let's suppose it really does. There's nothing that it can think of that they can put into rulemaking, get implemented, and actually produce results in a year. Those are big changes in payment systems and delivery systems. Everyone knows those are important. They're not going to happen in a year. So, in fact, IPAB's structured to squash any unlikely success you'd get out of the Center for Innovation. So I think it's at odds with conventional practice in its setup. I think it's internally inconsistent with what is claimed for the Affordable Care Act, and that's why I think it's a deep policy error.
I do think that IPAB goes further than any legislation, any board in my experience, and that it has not only the ability to have the force of law, but there's no administrative or judicial review. And its provisions go into effect unless Congress reaches extremely high hurdles in overruling it, and then, as we discussed earlier, having to achieve the same targets. And I think that Doug makes an important point in that the CBO has already shown it's not going to score quality improvements as really showing meaningful savings, especially in the one-year time frame that the IPAB has. And so its only tools really are going to be more cuts in payments on the existing fee-for-service system. And we know where that goes, and we know where that leads as far as payment rates and access to physicians. So I think the miracle that Ms. Moore was talking about earlier is Part D. We know that the marketplace competition consumer power will get prices cost down for government programs, and that must be the way we go.
Ms. Wasserman-Schultz.
Thank you, Mr. Chairman. I think we need to recap. Let's compare Medicare for seniors under the Affordable Care Act and Medicare for seniors under the Ryan Republican plan that passed as part of the Republican budget. Under the Affordable Care Act, the donut hole is closed over 10 years. The actual, not magical check, Mr. Holtz-Eakin, of $250 that seniors received last year paid for actual groceries, paid for, excuse me, Mulvaney, you're sitting behind Mr. Holtz-Eakin's nameplate, forgive me. The actual $250 check, not magical, pays for actual groceries, pays actual mortgage, is actual money. So to suggest that somehow the $250 check is mythical or magical or non-existent is completely false. I've stood in front of numerous town hall meetings in my constituents, asked for a show of hands of how many seniors got a $250 check last year, and plenty of actual hands go up. The 50% cut in name brand drugs, the gentleman wonders how it's paid for. I'll remind the gentleman that the entire Part D prescription drug plan was never paid for by the Republicans and added $400 billion to the deficit over 10 years and $7 trillion to the deficit over 75 years. So when it comes to who made sure that we reduced costs in Medicare, who made sure that when we passed new policy that we ensured that it was paid for, Democrats did so and preserved and protected and extended the life of Medicare, and Republicans jeopardized it. In addition, the Affordable Care Act adds preventative screenings, like mammograms and colonoscopies, that used to have a copay before the Affordable Care Act passed and that now are free, which means that we shift the focus in Medicare from a sick care system to a wellness and prevention system. And we ensure that seniors can stay healthy, and we save health care costs down the road, because if they get screenings up front, then they are less likely to get sick down the road. A wellness checkup, which was not something seniors were entitled to before the Affordable Care Act, a free annual wellness checkup. Now they are entitled to that, again, being able to preserve their health rather than having them access the healthcare system for the first time once they're already sick, which we know would increase costs. So let's look at the Republican plan, the Ryan Republican plan to end Medicare as we know it. Gives a voucher to seniors and leaves them to the whims of the private insurance companies to get health insurance on their own, and adds $6,000, actually more than $6,000, to the bill of Medicare beneficiaries of seniors, all in the name of making sure that we can preserve tax breaks for millionaires and billionaires. So, Dr. Fetter, if I can ask you, as you know, we've had some discussion this morning about the IPAB and what it can and can't do. It's explicitly forbidden from recommending any changes in premiums, any changes in benefits or eligibility or taxes or other changes that would result in rationing. So through those prohibitions, the IPAB can't increase Medicare beneficiary premiums or cost sharing at all. They can't decide to just tell a doctor that a knee surgery is $1 and that's the end of the story. So accuracy is important. Do you agree with the assessment that seniors could face higher out-of-pocket costs as a result of the Republican Medicare plan? And could you respond to my comparison of the two approaches to how we preserve Medicare and make sure we bring down costs and protect seniors?
Thank you, Ms. Westman-Schultz. I do agree with your assessment, and let me give my interpretation of how that occurs. As I indicated, the voucher that is in the Republican budget is taking all the reductions in payment growth that we've talked about into account. That's all been accepted by Republicans in the House. And gives a budget, then gives a dollar amount for seniors to purchase private insurance, which the Congressional Budget Office says is already more expensive than the Medicare plan for seniors, and will be much more expensive in 2022 when the voucher is expected to start. What that means is we are sending seniors on their own. We'll be sending seniors, myself included, on our own to shop for benefits without the ability of having the government behind us to negotiate or set prices on our behalf, determine that the benefits are what they ought to be. So it is simply a cost shift that, according to the Congressional Budget Office, actually increases cost to seniors.
And would you say that it sounds to me that there's no debate over those facts, and those facts are inevitable.
I have not seen any. I think that's definitive.
Thank you.
Thank you, Mr.
Good place to
McClintock.
leave it, Mr. Chairman.
Yep, Mr. McClintock.
Well, following up on the question of jeopardizing Medicare, Mr. Holtz-Eakin, can you tell us what are the projections actuarially for the bankruptcy of the Medicare system on its current course?
The Medicare system as a whole is bankrupt now. I mean, it simply cannot pay its bills on a cash flow or a projected basis. The trust fund for Part A, one tiny little piece, is expected to be exhausted in a bit over a decade.
So continuing down the road we're on right now, which is basically the Democratic approach of assures the destruction of Medicare as we have known it or have ever known it.
I couldn't agree more. The status quo is dangerous to the beneficiaries, to the budget, and to the economy, and we have to change direction.
One thing that's scaring a lot of the folks in my district right now who are on Medicare is they're beginning to feel trapped. They're finding it harder and harder to find doctors who will take Medicare patients. They're having to travel farther and farther when they find those doctors. Do you have any, that's anecdotal, what's the data on that?
Well, I mean, the latest survey data that I have in my written testimony suggests that 2/3 of physician practices are reviewing their treatment of Medicare beneficiaries, and some of them will be aggressive enough as to not take any new beneficiaries. Some are contemplating it, but each time we go through an episode with both the sustainable growth rate and now the Affordable Care Act promise to cut provider payments, they react in a very sensible business fashion. They say we can't afford to do this, and they don't.
So someone's turned 65, they have to give up their insurance for Medicare. They're now trapped in the Medicare system. They're finding it harder and harder now to find a doctor who will treat them. What's their alternative? What can they do if they can't find a doctor who's willing to take the Medicare reimbursement rate or have to travel an exorbitant distance to find that doctor?
Pay out of pocket 100% of the cost, which is exactly the dilemma that Ms. Wasserman-Schultz was highlighting.
Mr. Stutzman put his finger on the subject, I think, when he pointed out to the study that a average couple earning about $89,000, retiring at 65, will have paid into the system about $110,000 and will take out an average of over $350,000. I don't think you have to be a secretary of HHS or even a member of Congress to know that that system is not, it cannot be sustained. It seems to me that there are two ways to address it, and those two ways are basically laid out in the approaches of the parties. One of them is price controls. The other is competition. Would you agree with that?
I do agree with that. I believe that my worst day as a CBO director is when a member of the other body asked me what the right price for inhalation therapy was in Alabama. And that is everything that is wrong with the Medicare system, and this continues it.
Well, that would also explain why we're now seeing a shortage of doctors. I mean, we've got a lot of experience with price controls. They date back in written records as far as Hammurabi, and they seem to produce very consistent results. They will, in every case I have ever studied, Diocletian to Nixon, they will produce a shortage of whatever it is that you are controlling the price on. Do you know of any exceptions to that?
No.
So we have a mechanism that we know will create a shortage. We're already watching it create a shortage. And we have now established an independent payment advisory board whose principal tool to hold Medicare costs down is to place more and more draconian reductions in the price controls that are already there, meaning a more and more difficult time for people to find doctors until you simply can't find them.
As I said, that is my deep fear, is that this will accelerate what is already broken about the Medicare system, and thus is something we can't afford to do.
Now, how would you describe the Republican approach to controlling these costs?
The approach is, I think, quite sensible in that it gives a finite amount of resources to a problem, and people, when they have a finite amount of resources, use it efficiently. It allows the best package of insurance benefits at the right price to be selected by the Medicare beneficiary, thus rewarding value, which is how we've been successful in the other 87% of the economy.
Competition.
Yeah.
Will and Ariel Durant, in their History of Civilization, asked the question, what makes Ford a good car? Chevrolet. The fact there's somebody there competing to offer better services at a lower price. But just in the few seconds I have left, the hit on that we keep hearing is, well, Medicare Advantage works that way and it costs more. Could you address that very quickly?
I believe that is a very mistaken statement. Medicare Advantage, when it is a managed plan, is cheaper and offers a better value proposition. The fee-for-service Medicare Advantage plans cost a lot because fee-for-service is broken medicine regardless of the label attached to it.
Thank you. Mr. Langford.
I want to get a chance to follow up on what...
I apologize, Mr. Langford. It's Mr. Van Hollen. He didn't have a chance this round.
Oh, glad to yield.
Thank you, Mr. Chairman. Let me thank all the witnesses, and I want to just very quickly on the Medicare Part C. We know from CBO and the facts that we had been subsidizing that at about 114% of Medicare fee-for-service. But really what I want to do is pursue the line of conversation that Mr. McClintock raised, because you in your testimony would suggest that it's like really, really hard to find a doctor on Medicare. We just heard that anecdotal evidence suggests it's harder to find doctors, and I think we should all agree that rather than rely on anecdotal evidence, we should just look at the real evidence out there. And fortunately, a nonpartisan group called MedPAC that advises the United States Congress does exactly that survey. And let me report to you what their most recent findings are, because I think it's it's informative on this issue. They talk about how every year they conduct a patient survey to overall access to care. And they look at the private market and the Medicare market. And I'm just quoting from their report. Results from our 2010 survey indicate that most beneficiaries have reliable access to physician services, with most reporting few or no access problems. Most beneficiaries are able to access able to schedule timely medical appointments and find new physicians when needed, but some beneficiaries experience problems, particularly when they are looking for a primary care physician. Medicare beneficiaries reported similar or better access than privately insured individuals age 50 to 64. On a national level, this survey does not find widespread physician access problems, but certain market areas may be experiencing more access problems than others due to factors unrelated to Medicare or even payment rates, such as relatively rapid population growth. Then, if you go on, it states the Patient Protection Affordable Care Act of 2010 contains several provisions to enhance access to primary care, including increasing Medicare payments for primary care services provided by primary care practitioners. Then if you look at the chart, the table they have, and I just want to read what they asked. This is a survey. This is an anecdotal. Getting a new physician. Among those who tried to get an appointment with a new primary care physician or a specialist in the past 12 months, how much of a problem was it in finding a primary care doctor/specialist who would treat you? Medicare program. The answer being no problem finding a primary care physician. 2007, 70% said no problem. In 2008, 71% said no problem. 2010, 79% said no problem. Let's look at the private insurance market. Age 50 to 64, all the things that people said would make it work. No problem has declined from 82% saying no problem in 2007 to 69% saying no problem. Now, 10% gap. In other words, Medicare beneficiaries, according to this nonpartisan analysis, have no problem. Specialists. I think it's important to get the data out because there's anecdotal. I hear from seniors in my district difficulty in access, and it doesn't mean that every single physician takes Medicare, just like not every physician is on the plan a lot of us have. I mean, depending on what you choose. But I can tell you, in 1965, Medicare beneficiaries couldn't find, people who 1965 and up couldn't find any physician willing to take them. Access to specialists, people who reported no problem with access to specialists. 85% of Medicare beneficiaries in 2007, no problem. As of 2010, 87% reporting no problem with access to specialists. Again, higher than in the private market, ages 50 to 64, where 82% report no problem with access to specialists. Mr. Chairman, I'd like to submit this for the record. No. And I do think that this whole conversation requires data. You know, the notion that all of a sudden, and Mr. Holtz-Eakin, you say in your testimony, today, you know, Medicare coverage no longer guarantees access to care. Well, it doesn't mean that every doctor, I agree, signs up to participate in Medicare, but the overwhelming number of doctors do. And in private plans, there are a whole lot of doctors who don't participate in private plans, and I can assure you that under the House Republican plan, when they're going to be providing a much smaller allotment, and you're going to be leaving it to federal employees to establish a standard benefit plan, but insurance companies to decide what benefits they're going to provide, you're going to have a real access problem. And I would ask Ms. Feder if she could just comment on that issue.
No, absolutely. I was listening. I appreciated what you were, that you read my mind, or we were on the same wavelength because of that MedPAC evidence. And but you had it first. It was in your mind. The issue that I've been thinking about is, what is it that you are thinking that these private health plans are going to be able to provide people in terms of access if you give such a limited voucher? People who can add on the extra dollars, maybe the very well-off seniors may be able to get a decent plan, but you're not giving them enough money to shop with. So anything that you even think may exist in the current Medicare plan is bound to exist when you've actually given seniors fewer dollars to pay for more expensive plans.
Thank you. Thank you, Mr. Chairman.
Now it's Mr. Langford.
I want to be able to respond real quick to a statement that Ms. Washman Schultz made earlier. And just talking about, there's nothing in this IPAP that's going to reduce costs or reduce reimbursements, or they can't change the prices on things, and that's just not in the law. In a meeting about 4 weeks ago that freshman legislators of both parties had with Timothy Geithner to be able to talk about some of the president's plan for dealing with deficit reduction in future days, we walked through section by section of many issues with them. One of them was dealing specifically with health care, because at the time the president had not released a plan for how to reduce costs in Medicare and Medicaid and what the plan was. He'd made multiple statements saying, we need to bring costs down, we're going to work on that. So we asked him the specifics of that. Specifically, Timothy Geithner stated the way they were going to get savings over the next 10 years in Medicare and in Medicaid is by cutting the reimbursement rate to doctors, hospitals, and drug companies through IPAP. So if this is not in the law, someone needs to inform the Secretary of the Treasury that that's not how we're going to get these millions and billions of dollars of savings. Because the president's spokesman is stepping out there and saying the way that we're going to accomplish this is by cutting reimbursement rates to doctors, hospitals, and drug companies to gain cost savings for Medicare and Medicaid. So it is very difficult for me to hear one person say that's not in the law, and then the Secretary of the Treasury say that is the way we're going to accomplish that. I also have difficulty in processing through the power that's been given to IPAP and saying, because there is medical innovation that needs to be done with how we handle the cost savings, we're going to give this power to this independent group and give them the authority to be able to accomplish this. This is a unique situation to say we have a very difficult issue. Apparently Congress is having a difficult time cutting back the costs on this. And so we're going to empower this group to basically create law. Well, here's my question that I would have asked Secretary Sebelius. GAO makes reports about how to be able to save money in HHS. I am interested, if IPAP has the authority to be able to make recommendations that require a supermajority from Congress to change, to giving to GAO the capacity when they do a risk assessment on HHS and cost savings, the authority to be able to make cost saving suggestions about that. And I would like to empower the Inspector General of each of these agencies to say, when you find fraud, or when someone rises up on the high risk list, which multiple agencies are on the risk list for GAO, I'd like to just empower them the same way IPAP has empowered them, give them the power of law, and to say, whatever recommendation you make about how to reform the Department of Energy, the EPA, the Department of Treasury, whatever it may be, let's just empower the Inspector Generals and the GAO when they make recommendations that they have that same authority with IPAP. Mr. Holtz-Eakin, do you think that's a good idea?
No.
Why?
Ultimately, I believe the Congress has the responsibility to make these policy decisions, and having made them, the executive branch has the responsibility for implementing them. Congress then has to turn around and do the oversight. That's the standard of practice in the United States. It has by and large been quite successful, and it's the practice I would suggest you adhere to.
Okay. Ms. Federer, what do you think about that? We go ahead and empower the Inspector General, and we empower GAO to go ahead and make recommendations, the same authority that IPAP has.
What I think is different, and what I think that the IPAB does is able to do, which is what I think Ms. Wasserman-Schultz was getting at, is to look at, to assess what's going on in payment and make recommendations, as Doug said, not so differently from the way MedPAC does, but with more authority to move them more
Not so
aggressively.
differently than what GAO does on all of our agencies.
Well, I think
very similar. I mean, they look at reports, they go through all these, they make recommendations, they say this would be a great way to save money, hand it to the Congress to make the decision.
Well, I think I would not advocate it. I'll go there. I think that we have an issue in terms of healthcare cost growth that requires this.
Quite frankly, we have an issue with agency growth.
Well, I'll stay where I am. I think that the nation's healthcare cost growth, not Medicare, that the nation's healthcare cost growth is a matter of dire concern. And I think that this is a mechanism which I would argue leaves authority in the Congress. The Congress can reject it with 60 votes in the Senate, or can come up with alternative mechanisms in order to achieve spending constraint. And I think that that at this point in time is helpful.
I would have to say that I don't think that's a good idea to give that authority to GAO either, or to the Inspector Generals. Neither do I think it's a good idea to give it to IPAP, to be able to say they have some supermajority that they can shut down and create law based on their recommendations. And with that, I yield back.
Thank you. Mr. Who do we got next year? Oh, Mr. Whittle, I think.
Thank you, Mr. Chairman. I appreciate that. Dr. Fader, I had a couple of questions for you. I appreciated what you closed your testimony with, that you think IPAB would be a wonderful thing for public and private plans alike. And we get so many shades of gray here. It's nice to have some clarity. Tell me about what Ms. Washman-Schultz said before she left the room. She said, we used to have a copay on programs, and now they're free. She was describing some of the changes in the President's health care plan. As we talk about rising costs and how to get those costs under control, when you used to have programs that had a copay and now those programs are free, what does your experience lead you to believe? Does that lower costs because you're getting more people into the system, or increase costs because you're having more utilization?
The question is which services, and the copays have been eliminated as they would be also for other people in the Affordable Care Act, and I think some of that's gone into effect as well for preventive services. And it's based on the premise that the getting service, getting a checkup, getting service early actually reduces the possibility of more costly illness down the road. It's based on, in some cases it does do that, in some cases it doesn't, but it's based on evidence that is tied to the importance. The best evidence, for example, is prenatal care, not for the Medicare population, but for the younger population, immunizations. So it's preventive service that this focuses on.
Now, I look at the Federal Employee Health Benefit Plan. I happen to have the absolute cheapest plan that's on the menu, and it's an Aetna health savings account. I have access to any physician I want to go to. I have access to any service that I want to utilize, and I pay absolutely nothing out of pocket for those. It all comes out of my medical savings account, and yet it's the cheapest program on the menu. Why is that true? Why is it that when I'm in charge of my care, I get the cheapest plan on the menu, but when all of the benefits are predefined for me, it actually turns into the most expensive plan on the menu?
I think one of the issues is who's choosing the high deductible plans, and so you have to look at selection and whether healthier people who do not expect to use services may be actually in those plans, because you do save on the premiums. And I would hope that you have been in good health, and I would venture to suggest that in all likelihood, so that the population being served is a generally healthier population. So I'd have to look at that selection issue before making a comparison.
I'm not going to quote you exactly, but as fast as I could write it down, as you were responding to a question, you talked about how we get sent out into the marketplace under the Republican health care plan to make decisions without the government to set prices on our behalf.
What I said was that we're as individuals negotiating with insurers rather than having the government, the public program, Medicare, as an insurer. And I think that I think that I'd prefer to have Medicare do it for me, based on what I see in the marketplace.
Thinking about your vision of having IPAB control private insurers as well, I did have to go in for a chest CT recently. Pulled up a list of providers online, shopped around for prices. There was about a threefold disparity between the one that was right next door to me that happened to be 3 times more expensive and the one that was about 4 miles across town that was a third of the cost. I got in the car, I paid the $4 a gallon to go get the one that was a third of the cost because it was coming out of my medical savings account. Why does government price fixing of a price for everybody across the board lead to a better outcome than me seeing those prices and making that decision on my own?
Actually, let me move it just a little bit to where the Affordable Care Act is trying to go in terms of, I think, having the an improved position over the fee-for-service, because I think that there is a problem with paying fee-for-service and having ever more expensive care. And I will share with you a conversation recently with a private insurer who would like to partner with Medicare in an alternative approach, a medical home approach, in which it would be physicians who would be rewarded for delivering care more efficiently, and it would be they in conversation and working with their patients who would be selecting the place that was best and most affordable, or most efficient. It's not an issue here. It's a most efficient. And I think that is a mechanism, and as I've said, we continue to sound, the conversation sounds as if we're heading down a continuation of healthcare healthcare system as we know it, when in fact the Affordable Care Act is moving us and leading and working with the private sector to move in a different direction.
Well, that plan that you described sounds strikingly like the PACE program that Bob Dole championed in the late 90s, where you combined Medicare and Medicaid together and let folks make those decisions. Thought that was a wonderful program. I hope we'll have a chance to get back to exactly that kind of.
Well, I appreciate your drawing on PACE, because PACE actually serves the most vulnerable dual eligibles, people on Medicare and Medicaid who need long-term care, and long-term care in particular is a major problem for people today, and I thank you for your interest in that program.
Thank you. If you could bring up chart 1, please. This shows a comparison of inpatient hospital services reimbursements. Right now, Medicare is paying about 66 cents on the dollar to providers. In the out years, it goes down to 33 cents on the dollar. That's where we are right now under current law. Next chart, please, chart 2. Doctors. Right now, we're paying about 80 cents on the dollar. Therefore, it's a little higher, and therefore the access is not so bad. By 2030, it goes down to 40 cents on the dollar. The SGR. We have played with this hot potato for a long time. And what we learned out of this experience, the 1997 budget agreement, which was really held up as a hallmark budget agreement, Republicans working with the Democratic president to get a budget agreement, which, by the way, cut taxes and cut spending. What we got out of that were price controls on Medicare and payment systems which are producing these results. In the current Affordable Care Act finishes the job in going that direction. And what we learned out of that, at least our lesson, was price controls don't work. Because like we said from Diocletian to Nixon, when you pay less for something, you get less of it. And so what we learned out of that was nursing homes are going out of business. They were just dropping Medicare. Home health agencies, the entire Medicare provider network was fraying at the edges, and they were just not going to take, they're going out of business and stopping the provision of Medicare services to Medicare. So we did 2 laws since 1997, BBRA and BIPA, plowing the money back to keep the Medicare system from imploding on itself, to keep the beneficiary access going. And so it has been said this morning that IPAB is a backstop, it's a fail-safe. What it is it's political cover for politicians not to have to make the decisions to cut reimbursements to providers. It's like the base closing commission. We didn't make the decision, somebody else did. And that, unfortunately, is where this whole thing is headed. Not just in healthcare, I would mind you, in other areas of law. And so here's what we know. 10,000 baby boomers are retiring every single day today. And a lot less people are following them into the workforce. For those people who had kids in the 50s and 60s, they did a great job. They had a lot of them. But we didn't have as much since then. So we're having about a 100% increase in the retirement population, but because this is a pay-as-you-go system, current taxpayers pay for current beneficiaries, we only have something like a 17% increase in the tax-paying population. In 2000, 25% of Medicare was subsidized with the general fund. We'd go out and borrow money in the credit markets to pay for 25% of Medicare. Today, it's 51%. It's going up. And so the problem we have is not that we don't have the political will to cut costs or reimbursement rates. We don't. But more importantly, we know if we just do price controls, we'll just deny access. The program will fall in on itself. So the solution to this problem from our perspective is not to delegate all these decisions to unelected bureaucrats, 15, to just arbitrarily make these decisions, and if we don't like them, we got to have a 3/5, we have to have a supermajority vote to overturn them and then replace those price controls with other price controls within Medicare somewhere else. The whole thing is designed to take accountability away from politicians, meaning people's elected representatives, and give all this power to 15 people to just do this unilaterally. But at the end of the day, our conclusion is this won't work. Because if you're paying a doctor or a hospital, 66 to 33 cents on the dollar for the services they're providing Medicare beneficiaries, they're just not going to provide that service. And so I don't know what you call that other than rationing by some other word. And so what we're saying is we have seen lots of evidence throughout history that choice and competition works. And we've seen lots of evidence throughout history that price controls don't. And so why do we believe in choice and competition? Because it doesn't put 15 bureaucrats in charge, it puts the person in charge. They get to decide. More importantly, having been on the Ways and Means Committee overseeing Medicare for 12 years, you don't want a handful of politicians, or let alone a handful of bureaucrats who aren't even elected, to play thumbs up or thumbs down on what providers can or cannot get for providing services. You want the consumer, the patient, to do that. More to the point, what we want are the providers of medical services to have an incentive to please us as consumers, to have an incentive to root out waste, fraud, and abuse, as they do today, and they root out a heck of a lot more than traditional Medicare fee-for-service does, to meet our needs. And since money is finite, and since we have an infinite funding problem with Medicare, our point is this. People who are already on the program, people who are about to retire, a promise was made to them. It's an unfunded promise. It's a promise at the lowest estimate, it's $31 trillion in the hole, but it's a promise that was made. Our argument is, if we get ahead of this problem now, we can keep that promise. If we start turning the curve on our fiscal problems, prevent a debt crisis in this country so interest rates don't spike and the 51% financing of Medicare from the general fund, which is borrowed money, doesn't go up, we can keep that promise. And so we think we should do that. And we believe if we do that, by getting rid of IPAB and therefore its price controls, we can keep this promise to current seniors. But in order to cash flow that promise and keep our borrowing down, keep our interest rates down, so we can afford that promise, which currently is unfunded, you got to change it for the next generation. And the way we should change it in the next generation is let's recognize that there are people in society with needs greater than others. If you're sick, you have greater needs than a healthy person. If you're poor, you have greater needs than a wealthy person. So let's put our money there. $7,800 more to begin with for a low-income person, and that grows every year. If you're sick, your payments go up. It's not a voucher. Everybody likes to say voucher. Premium support and vouchers are two distinctly different things. A voucher is you get your money, you get a check in the mail, and then you go out and buy something with that check. It's not what we're talking about here. Just like prescription drug benefit. Medicare pre-screens a list of plans, just like they do for federal employees, and you choose your plan that's Medicare certified and regulated. And then Medicare subsidizes your plan. More if you're poor, more if you're sick, less if you're wealthy. Why? Because wealthy people have more money, so they can afford more out-of-pocket cost. But more importantly, these providers have to compete against each other for our business. And so if a woman on Medicare doesn't like her plan, she gets to fire that plan and get another one next year. More importantly, that plan knows it. If they don't make her happy, if they don't give her what they say they would at a competitive price, she'll fire them and she'll go to their competitor. That's why Ford's better, because of Chevrolet or because of Toyota. And that's the whole concept here. The problem we've got is we think we can do this on the cheap. We think we can just fix this problem if we politicians wash ourselves of the responsibility and let some distant bureaucrat make the decisions. I've seen it so many times where a constituent will come and complain about what the government's doing to them, and the elected representative says, I wish I could help you, but I can't. It's something the bureaucrats do over the executive branch. That is not what this country was designed to be like. It is not democracy. It is not government by consent of the governed, and it won't work. And so what we're simply saying is we don't believe that this works. The other 80% of our economy functions on choice, on competition, on price. We want to inject those market fundamentals, transparency on price, transparency on quality, and an economic incentive to act on those things to fix this problem. And so we just have a very difference of opinion. And Mr. Holtz-Eakin, I just simply want to ask you, in closing, If we do the SGR like we always say we will, and we will, I have no doubt, we will stop doctors from getting cut 29.4% this year and then stop it again next year because we are in control of it, elected representatives. If we do that, what will be the general fund transfer to Medicare in the future? Medicare is already being financed 51% of its budget by floating bonds and borrowing money. If we stop those cuts, because right now Congress can, IPAD doesn't run that right now, what will be the general fund transfer with borrowed money going into the future?
Well, I mean, we know that just keeping payments level for 10 years is going to cost well over $300 billion at this point. And, you know, you're raising that 51%, something that probably is going to be closer to 55, 60%. I have to do the math to get an exact answer. I'd be happy to do that.
So I just want to ask, Ms. Fader, Dr. Fader, you say that we ought to have an IPAB for all of healthcare. Do you believe that we can better sort of organize or plan the healthcare system if we can put IPAD in charge of the rest of the payment systems for the private market as well, from age 1 to age, to the end of life?
What concerns me, Mr. Chairman, is that it is an assumption that the private sector, when you do your 30 cents on the dollar or 60 cents on the dollar, that dollar is somehow immutable as to what health care ought to cost. And what we've seen, and MedPAC documents, is that where the private sector, along with Medicare, is actually working with providers to slow cost growth, or adopting policies to slow cost growth, hospitals are not losing money on Medicare because they've become more efficient. It's where there is not that kind of behavior in the private sector. That essentially the private sector cost growth, they offset whatever is constrained on the Medicare side, and providers continue to operate as they do. So I think you do get me. And what I'm saying is that we need to change the incentives for the entire healthcare system.
I don't think anybody really disagrees with that. So I can't think the difference here in execution is, instead of having one experiment run by the federal government where we are subject to the whims of their decisions by an unelected bureaucracy, why don't we have more than one experiment? Why don't we have a marketplace that is designed to compete for our business, but more importantly, give people power? Give people power, especially on Medicare, that they can't be denied care when they choose their plan. Give low-income people a lot more money to cover all their out-of-pocket costs, and not as much to higher-income people. Ms. Turner, let me ask you the final round of this. Is where do you think this is going to head if we stick with the current law? What is the world going to look like in 10 to 20 years if we just basically freeze the law in place as it is today, as it's coming into? What's it going to look like?
Well, Mr. McClintock was wondering what people will do, and I think we can look at what happens in Medicare today. People go to emergency rooms to get routine care because they can't find a private physician to see them. And I believe the current MedPAC statistics show that the fact that the Congress has continued to do the SGR fix has allowed access to continue. But the important thing is that this legislation assumes that deep cuts down to 33% of current private payments go into effect. That absolutely is going to have an impact on patient care and patient access to care. And the choice that the chairman's been talking about is really the way to move to a different system. It's really not, can we fix this system? We know Congress has tried everything it can do. And now instead of trying to fix it, we're going to put more restrictions, more bureaucrats in charge of making decisions about payments. And that can only lead to restrictions on access to care, to physicians dropping out of the programs, to people, as we see in Medicaid, as we see in Europe. In Canada, in some provinces, a quarter of citizens can't find a GP, an access physician, to see them. They wind up having to go to hospital emergency rooms. That's what I worry, is that we're going to relegate people to those kinds of access systems that are not the promise they've been given.
Dr. Holtz-Eakin, you want to jump in?
I just simply believe that Grace Marie is too optimistic. I mean, that answer presumes that there remains the capacity for the rest of the U.S. budget to transfer to Medicare enormous amounts of resources, and the only fight is over how much of that goes over and thus how much turns into increased budget costs versus restricted access. That's not going to be true. We know the projections for the overall budget, and we know that when they hit a certain point, the underlying 80% of the economy from which the healthcare sector is now drawing all of its money is going to collapse. And so we have a problem that is bigger than just a genuine and serious problem with beneficiary access to care. We have a problem that mutates past that to being a fundamental threat to our economy. And so the choices that we made in the future, if we don't change direction now, will not be the choices we make. It'll be the bankers' decisions on how this all gets run. And that is not a future we should tolerate.
Well, thank you very much. I appreciate the indulgence and appreciate everybody's time. This concludes our hearing.